We'll have neuromodulation for low back pain by Dr. Caporal. And then we have a question and answer time. And then we have a 10-minute break. We purposefully kept the break because sometimes, the attention span goes down and people need a break. So we kept the break for 10 minutes. And then we'll have Professor Varacci from Italy talking to us about multimodal analgesia for chronic pain management. And then after that, we have a Q&A question session. And then we have joint denervation webinar, so joint denervation lecture, journey from cadaver lab to clinical application from Professor Maxime Ekman from United States. So we have expert faculty and our moderator, my colleague, my friend, Dr. Reda Tolba will do detailed introduction, but we have expert faculty, Dr. Tim Deer from United States, and then we have Dr. Leonard Caccarel from United States. We have Professor Agostino Varacci from Italy, and we have Professor Maxime Ekman from University of Texas, United States. So, this is basically, what we're planning to do is to spread the education in the field of pain management. So we have got face-to-face cadaver course lined up in Ajman, which is about 45 minutes drive from Dubai. And it's on 26th of March, we have a spinal interventional pain management. And 27th of March, we have joint denervation course and joint interventional pain management. So we have a hybrid event. This event is hybrid. So we have a face-to-face kind of, these are the flyers for the face-to-face. And then we have a sort of online virtual event that's taking place. On 28th of March, we're going to do webcasting of these cadaver procedures of lectures. And 3rd of April, we're going to do webcasting of major joint interventions. Both of these courses have CPD points. All the lectures are recorded. So if you can't attend the live session, you can actually access the recording. So, these are the flyers. And we do have coming soon. So this guy is Professor Bernard Murgel, very, very well known in the field of ultrasound in pain management. And he's done, multiple publications, multiple books he's written. So we call this as a, ultrasound in pain medicine, anatomy, sonoanatomy masterclass by Prof. Murgel. And he's going to be doing this in the month of April and May. And we have confirmed 12 CPD points from the Royal College of Anaesthetists. So these are the dates. All the details will be available on the Gulf Pain School website. The registration is live on bookcpd.com. So now, quick announcement. It's great pleasure to have all the big guns in the field, all the legends in the pain management. We are announcing, like Netflix, we are announcing Painflix from Gulf Pain School. We have, the Painflix will go live from today. And we have an intro video, which I'll play during the break. So that's me, and I'm going to stop. So do join us on the social. We are on LinkedIn, Facebook, YouTube, Twitter, and Instagram. Thank you so much, guys. And I'm going to pass over to
Sadiq, yes, if you can admit our speakers.
Yes, we have. Yes, we have.
Agostino as co-host.
Absolutely. I'll do that now. 2 seconds.
Okay.
So, Dr. Deer, we are ready for you. So if you want to share your slides and...
Dr. Reda will take over. Yeah.
Yes.
So again, thank you everyone for attending the session. We're very proud to have not just world experts in the field, but basically an inspiration for all of us. Dr. Timothy Deer has been leading the field of pain medicine and neuromodulation for more than 3 decades now, and he's an inspiration. He's the president and CEO of the Spine and Nerve Center in West Virginia, and he's a clinical professor of anesthesiology and pain medicine at West Virginia School of Medicine. He's the chairman of the ASPEN, American Society of Pain and Neuroscience, and also he's an Ironman finisher, and he's basically an inspiration for all of us, not just in the field of pain, but in a lot of things in life. And I am proud to actually, if he wants to give us a short talk before about ASPEN and ISPN, and we kind of launched the international division of ASPEN recently, and we want to have our first webinar at the end of May. And without further ado, I'd like Dr. Deer to take over, and thank you again for being with us today.
Well, thank you both, and certainly it's an honor to be here. And I've been watching the Golf Pain School and what you've done. I've been very impressed over the last few months, and what you've done during this pandemic has been really inspirational because a lot of people have not been educating, and you've been educating. So it's an honor for me to join all of you. And
thank you so much. Thank you, Sam. Thank
you. Very, very good. You've done a great job. Really great job. Dr. Tolba is certainly a dear friend and is now leading the international portion of Aspen, and with the goal of partnering with other great societies and schools like yours to continue to advance the field. And Dr. Tolba and his colleagues at the Cleveland Clinic Dubai is going to be, I'm sure, extremely helpful to all of you. And Dr. Amar and Rita both will do a great job there, I'm sure. I'm going to spend 30 minutes exactly, and so I'm timing myself so I don't go over. So I'm going to spend 30 minutes. I could talk about neuromodulation for 30 days. So I'm going to spend 30 minutes. So I'm going to be a little bit, superficial, going over things. It won't be maybe as in-depth as I would like to be, but we'll keep it on time here. Here's my disclosures. I do a lot of research right now. I'm involved in both the Saluda second closed loop study. I'm involved in 2 studies with Burst. I'm involved in the mainstay follow-up study. I'm in West Virginia. I've been involved with the INS and with NANS and with ASA, but now I'm currently working with American Society of Pain and Neuroscience very closely, and our international component there, and over in there in the Middle East. I'm having a little bit of trouble moving my slide, but let's see if I can get it to go here. So I kind of say this is kind of like, Rita mentioned my background. I'm a little addicted to sports, and I do a lot of ultra running where I run across deserts and do things like that. But this is Ironman Hawaii, and we didn't get to have it last year. We're going back, but I always think of us. I'm in this yellow. I'm to your right of the screen in a yellow swimsuit with an orange cap on. I always think of us. We're kind of always wanting to jump into the water with new things, and so there we are on the field of neuromodulation. There's something new. When do we jump in, and where do we go? And so it can be confusing. And let me tell you, when you get in that water there, it's pretty confusing. You get hit in the face a few times. You get punched in the head. You get kicked. But at the end of the day, you get out of the water. So hopefully we can go through these new therapies and offer some great things for our patients. That's kind of our goal, I think, overall. So spinal cord stimulation today is very different than it was in the past. Certainly we really see an evolution of stimulation. So, we think we've done a lot, but really if you think about the longevity of stimulation, we have a long way to go. We actually have had this period of time where we thought we made a new electrode. We thought we were doing something. We made the battery a little bit smaller. We thought we were doing something. We came up with a new technique where we put something through a different size sheath. We thought we were doing something. We could recharge batteries, then not recharge batteries, and then recharge batteries. And we come up with all these different paradigms. But really, I still feel like we're really a long way to go. And so I had a bunch of fellows ask me recently if there was anything left to invent or do. And I said, I think we're this far into this journey, and there's a lot of things to do. And so we have a long way to go. And even though we applaud ourselves in the back, if you compare us to pacemakers, for example, pacemakers can change with the patient, with each individual patient. And I think we're going to see the age of artificial intelligence and neuromodulation. I think it's coming. I think we're going to get to where, we can know what's going on in the nervous system. And I'm going to talk a little bit about that today. And then Dr. Caporal may follow up with some of that as well as some of his comments. So I think, we're going to talk about what we can do. If you think about the published efficacy, the other thing we have to realize is we've got a long way to go. We've got, certainly look at these explant data papers, and these are multiple studies. Loss of efficacy occurs still in a lot of patients. And if that's true, we have loss of efficacy in a lot of patients, then how can we get better? And so this overview I'm giving over this time is about how can we be better and get better outcomes so we have less explants. And in our practice, we looked at our own data, and we had about a 12% 5-year explant rate, which is pretty good. But still, we'd like to get to no explants if possible. And that may be a pipe dream, but I'm going to talk a little bit about that. So I'm going to cover different sections. The first thing I want to cover, and I'm going to spend probably about 8 minutes on it, is dorsal root ganglion stimulation. And again, the dorsal root ganglion, just to review anatomy, since some of you may have been in medical school a long time ago, it lies just below the pedicle in the epidural space. And the DRG is a processing center for all peripheral nerve type of neuromodulation. So it comes in, and our goal as we develop devices to put around the DRG is to change the way the process occurs at the dorsal root ganglion. So it changes the pain signal from the foot or the hand to the cord to the brain. So if you think about this, why is this such a good target? Well, this target is good because during states of things like this, which is hypersensitivity, CRPS type 1, for example, the DRG becomes extremely hypersensitive and it actually emits all kind of neurotransmitters that's going to keep that pain state going. And that's why you get that change in the limb. So if we can affect the dorsal root ganglion at the cellular level, and here's a look at a micron electric picture of DRG. If we can change the way that process is at the cellular level, we can change the patient's life. And so that was our goal with DRG. I did the first DRG in the world in 2008. So now here we are 13 years later, and we're still talking about why it's important. When there's pathology in a peripheral nerve, for example, I saw a man last week, he had his fingers, he came back for his 1-year visit, had his fingers blown off in an explosion, and he went on to do very poorly. And we put a DRG stimulation system in his C6, C7 area, and he did really well. But the reason he did well was we're changing the way the glia and the nerve fibers are firing at that level. So that's really the anatomy of that. So if you have this primary sensing neuron going off after the injury, what happens is you have that process that really the electrical current should stop, but it continues. So your body is saying something's wrong. Even when something's not wrong anymore, your body keeps saying there's something wrong. So it keeps triggering the A, delta, and C fibers, keep triggering the DRG up to the dorsal horn. Now, if you look at why we can do something about that at the T-cell junction, if you stimulate in a model the T-cell junction, what happens is electricity makes it go down. So you actually decrease the signal at the cellular level by putting electricity on that actual T-cell junction. So that's really the whole mechanism. I've simplified into this one slide. That's the mechanism in which dorsal root ganglion improves patients' pain signals and improves their overall function. And so that's something that we see there after baseline, then after stimulation. And if you cut the DRG, you see the same sort of disappearance. The reason that didn't work long-term was because when they tried things like dorsal root entry zone lesioning, the nerve came back and had deafferentation syndromes. So cutting the nerve or even ablating the nerve doesn't seem to work or last if you do enough ablation or damage to actually change the pain signal. So let's take a typical patient. We really went back and looked at the feasibility of this many years ago. This is the first study we ever did in 2011. And what we found was not only did it help the limb, these are all people that had nerve injuries, 10 patients. This is a very small feasibility study. But if you look to the far right, look at the back pain. You know, there's a few patients that had back pain. Their back pain went away. Now, why is that important? I'm going to show you because we have a couple of new studies showing that back pain may be reduced by dorsal root ganglion stimulation in those with either failed back or discogenic back pain. So we may see an evolution of DRG from the peripheral nerve injury patient to the axial back patient. I know Dr. Capral is going to talk about low back pain next, but I think that is going to be an interesting evolution. Now, also the thing about this, I just want to show you the current technique that's been shown to be most successful is this technique. We do an epidural, we take a sheet, we put the lead around the dorsal root ganglion just below the pedicle, and we make loops in the epidural space to keep it from moving. I always say that this is like a ballet because you really learn to do it with your hands where you get actually very used to that motion, and it's really been a way to stabilize the lead. I'm currently working on 2 new approaches, and I'm actually in Texas today. I'm going to be going to a cadaver lab later today. We're working on a paddle approach and a transforaminal approach. So stay tuned, but this right now has been the best method that we have found to keep it in place. We did the level 1 study on DRG versus normal stimulation published in 2015. This led to FDA approval. I know we have quite a few Cleveland Clinic people on this call. Dr. McKell was the senior author on this paper, as you see, and I worked with Dr. McKell. He was our safety monitor during the course of this study and did a wonderful job. 154 patients, 152 patients, 1-to-1 ratio of being randomized, and then they 3-month visits, 6, 9, 12-month visits. And what happened was there was a marked improvement in that group that got DRG. Now, why is that important? Well, because, and here's a slide I presented at ASRA a few years ago, it's been repeated over and over again around the world. So you may see some names there you recognize from parts of Europe and the Middle East. We actually have seen this same data, and you see the ACRIT study, which is on the far left. And when I made this slide, it was 570 patients over 6 years. Now it's 986 patients. And all those studies show a really amazing reproducibility. And I think that's really what's important. We have to be able to reproduce our data. So what's new with DRG in the last few years? Here's a paper by Frank Hagen with Leon Lehm and others over in Europe. And they looked at using L2 DRG to treat low back pain. Now, this study was thought to be somewhat interesting because no one had ever really shown DRG to treat anything but nerve injury. So I think that study really showed a good, it was presented at WIP. And then that was followed up by Dr. Kalleward, who's in the Netherlands. And I went over and this is me and him in his operating room. We did 6 cases together right before COVID hit. So I had privileges there at Santaneus. And so what happened was he presented L2 and had phenomenal results with L2 with low back pain. Ken Chapman in America has done T12, and now it's had 54 patients reported. And now we're starting a prospective randomized low back study with DRG. So I think that may be the future. Cervical DRG has been used in some parts of the world. There's been some complications up at C2 when they tried to treat occipital nerve pain with cervical DRG. So I don't recommend going above C6 or C5 at the very top. So I think if you're doing that, I do all my DRG under general anesthesia with neuromonitoring. My partner does it awake. So I think just as long as you have someone to be able to talk with you or have neuromonitoring. And this is a paper we wrote about best practices. And in that paper, we talk about proper routes of neuromonitoring if you're going to do it general anesthetic. Dr. Barani, you see, is one of the authors there. He did some of the first cervicals in the world, him and Dr. Verrills. And I was able to go over to Oxford and work with Dr. Barani in the cadaver lab there before we started doing cervical. So Dr. Barani did cervical prior to me doing cervical. Now, I know Dr. Capral's going to give you a whole talk on low back pain, but I want to just have a few, what I think is important highlights about low back pain. And then I'm sure he'll expand on these. Dr. Alkazi, a dear friend of mine, showed this study showing that at 36 months, you could get low back pain patients. And some of these patients were what we would call a maiden back or a virgin back. They had not had back surgery. So that result was quite significant. So I really think we have a future of treating patients who are not candidates for back surgery. And right now I'm involved in a study called Distinct. It's a 30-center study in America led by the Mayo Clinic, where we're looking at non-surgical back patients with the burst waveform. So I think all of these waveforms have great potential if used properly. But we always have to be cautious if we're believing what we say, and we have to always prove what we say. And so Jose de Andres in Spain did a very similar study where he took HF10 versus conventional stimulation for low back pain. And at 12 months, he found no improvement. And this was published in the journal Pain Medicine. You see the reference there at the bottom. So you have, on one hand, you have this paper by Alkazi saying we can treat the low back with great results at 3 years. And then you have Dr. de Andres saying we can't treat it at all with HF10 or with conventional stimulation. And my conclusion would be, you saw a moment ago the reproduction of DRG. We need to make sure we look at why we fail and why we succeed, because I'm sure these studies are both true. There are some people that do really well, and there are some patients who won't do well at all. So I think we need to really look at that closely. Now, one of the reasons it may fail is because as people move around, as you walk, as you talk, as you laugh, as you cough, the epidural space moves. And as it moves, whether you're getting tonic stimulation, whether you're getting high frequency stimulation, whether you're getting burst stimulation, what happens is that the number of signals to the nerve, the ECAP, if you will, changes. And this also changes based on how much CSF is there in the certain region, or what medication. We've shown now in studies that if you take gabapentin or an opioid, it changes. In fact, I just published a study showing the higher your opioid dose, the worse your outcome with both DRG and with other forms of spinal cord stimulation. So I think that's very important. Now, we did this study recently called closed loop feedback. And we just published this in the journal Lancet, which I'll show you in a moment. And what we found was when you measure the ECAP, this is the first time it's ever been measured. That's why I said when I began this talk, we're in the beginning of the era of artificial intelligence for stimulation. And this is the first version of that. So if you look at that on the left-hand side, you see that graph. You see how when someone coughed, lean back, lean forward, lie down, the amount of signal, the amount of nerves firing changes. That's why they may get no outcome or a good outcome based on their activity level. So if you can go in there and actually read that and change the way it looks by the way it's stimulating, then you'll actually see a difference here. And so that's really what's going on with that whole process. So we did the EVOKE study. And if you haven't read this study yet, it's in Lancet Neurology, published last year. And again, what we did, a multi-center, parallel, double-blinded study. This was the first ever blinded study in neuromodulation. Why was it blinded? Because everyone got the same device. Everyone got their nerve measured, but only one arm had feedback loop turned on, closed loop. The other arm was open loop. And so what we found was in 134 patients, 13 sites, that I could show a major difference. And I'll show you what it looks like on the next slide of the outcome. Here's a tracing of one of the patients. Here's the same patient with fixed output and closed output. And you see the difference there in the therapeutic window. The therapeutic window is defined here as when the ECAP, the action potential activation, and ECAP is a combination of multiple action potentials, can be measured. We can keep that in the same therapeutic range the whole time. So that's really pretty impressive. And that correlates to back pain improvement. Here's our data on 3 months, 12 months, and 24 months. And again, what we're looking at here is closed loop in the blue, open loop in the orange. So this is, again, pretty significant improvement, which leads us to believe that eventually most systems may have a closed loop mechanism. This study was sponsored by Saluda, but most studies will show us in the future that most devices will add the closed loop, with a couple of exceptions. If you have a waveform that actually works in the brain, you may not need closed loop. So we don't know that yet. We'll figure that out as time goes by. And so certainly here's a look at the paper. And again, the fact that it was double blinded was closely validated. And there was also, I think it's important to note, there was a script of the investigators had to use when they talked to patients in programming. The reason that's important is because some people feel that you can bias a study by what the programmer says. So the programmer said the same exact thing to both groups so that the patient wouldn't have any different vocabulary or discussion. The physicians had no clue which group the person was in. And we actually surveyed that to make sure that was accurate. So that was true overall. And then we also did the same sort of study in Australia called the Avalon study. And now here's a look at the 3 studies. And then in Europe, we actually had several Europeans now doing an open label registry. And here's a 12-month data of the 3 groups. And what you see here is a marked similarity between Europe, between Australia, and between the US. And again, to me, reproduction of studies is going to be very, very important going forward, because if you can't reproduce it, then you aren't going to do well. 84% of these patients were high responders, with 50% having over 80% relief. So what that 50% number is, that's the number of patients at 2 years who have greater than 80% relief. 84% of people had greater than 50% relief. So it's a pretty impressive number overall. And that's what it looks like compared to other studies. So I think that this is so far the best data we've seen of any peer-reviewed, published, randomized prospective study in the literature. And it's the first one with closed loop. Now, I have about 11 minutes left. I will stay on time, I promise you. But I just want to now shift gears and talk about Dirk de Ridder's work in Belgium and New Zealand, looking at the burst waveform, which he developed. And what it is, it's a theory that we can send a signal to the cord and change the brain. And this theory was that if you used a burst firing pattern in the cord instead of a tonic firing pattern, you would actually change the thalamus in the medial pathway. And what I mean by that, you have the lateral pathway, which is your numeric rating score. So when you think about the lateral pathway, which is what all stimulation tends to affect, our goal is to get someone's pain from an 8 to a 4, or a 9 out of 10 to a 2 out of 10. But the theory behind the burst waveform is we change the suffering pathway, which is your emotional pain. That's the goal. And so that's a totally different thought process overall. Now, I first met Dirk in 2004. And when I met Dirk, he was talking a little bit about tinnitus. In 2010, he brought bursts to the World International, the WIP meeting. I spoke there with him. And then Corey Hunter in the United States led a study I was part of, looking at people who were actually failing whatever therapy they may be having from different companies, different types of devices, different waveforms, and went in and added the burst waveform to those people, either by changing the device or just adding the program. And what you saw here is that a significant portion of patients could be salvaged who were failing. Now, what is the take home from that in my mind? This was published in the journal Pain Physician this past year. I think the message is if you only have one waveform in a patient, your chance of failure goes up. You want to have more than one option when possible, whether that be feedback loop or different target or different way to program. I think it shows that some patients will fail. And if you have another alternative, you may improve our explant data numbers. So in the United States, we did the FDA study. I led the study, published a few years ago, to show if we could actually get improvement versus what had been a conventional waveform or tonic waveform. In that study with 100 patients, again, out to 2 years, what we found was not only did we get improvement in the limb, but also in the low back. So that was really one of the first studies to show clinically significant differences in low back stimulation. And again, some of that is in non-surgical back patients. So we keep seeing this trend among these studies to maybe treat people who haven't had back surgery, who may not be candidates for back surgery. It may have discogenic pain, for example, that isn't curable by surgery. So this is the Sunburst study, which was published it led to FDA approval. And again, let me go back and look at consistency. The Sunburst is on the left. And what we showed here is that if you look at the first 3 bars here, we showed that the Sunburst study, that this new waveform was superior to tonic. You see that one beside of that, Sunburst optimized. We cut the amount of energy by 40% and we got a better outcome. This was the first hint we had that we're overstimulating patients. And I believe that to be true in many cases. And you see this reproduction here. You see a lot of your colleagues, many of whom you may recognize, all the way out. And here we had going forward all the way until 2019. And there's been another 500 patients added to this since 2019. Again, reproducing the data. So we have to keep reproducing the data. Here's a study I presented last year at NANS, where we actually then took that idea and did a feasibility study. And what we did here, when we did the Sunburst study, people had the waveform 100% of the time. It went on 24 hours a day, 7 days a week. They get the same waveform. If we gave them a waveform that lasted for 30 seconds on and 3 minutes off, or 1.8 hours a day, in some patients, and I'll show you the results in a moment, could we get the same or better results using almost no electricity, which means you don't need to recharge a battery. It can last a long time. You make batteries smaller. And so what we found was, actually on the other side, what we found was in this study that over half the people did well with 1.8 hours of electricity a day versus 24 hours a day. And they actually did better than those who got continuous stimulation. So now all patients we implant with this type of waveform in the US, we're implanting on what we call the BOLD protocol, which is a protocol of lasting 30 seconds on, 360 seconds off. Now we've gone to 120 and 480, and we're going to see how far we can go with this with a new study that we just designed, and we're going to start in the United States enrolling hopefully later this year to see how low can we take the electricity with some of these new waveforms. And think about it, if we can get the electricity really, really low, we may get where the batteries become 5 or 6 cc's and not have to be recharged. That would be revolutionary. Here's the Evoke study I mentioned to you a moment ago. This is the actually article. If you want to look for that, it's February 2020. That's the feedback study I showed you a moment ago about that. Now I have about 8 minutes left. I want to finish with a few other new things that you may or may not have exposure to yet in your practice. We know the multifidus muscle is a stabilizing muscle that keeps your spine erect. And when you get weak, MRI shows after chronic back pain, the multifidus muscle gets smaller and atrophies. And so in the past, really, we've had trouble getting those people rehabbed. There was a recent study performed both in the United States and outside the US, where we took a lead a tined lead and put it over the you see the medial branch nerve at L4 to stimulate the multifidus muscle. We did this with ultrasound guidance, so we can see the multifidus moving. It's pretty impressive to watch, actually, under ultrasound, and with fluoroscopic guidance to place the needle. And then an IPG goes in the body. The goal here is to override the underlying inhibition, reactivate the muscle control, and restore the functional ability of the spine. So this has been FDA approved now in the United States. Here's a look at the response. We see here a good outcome overall, both on ODI and on pain response over the course of 3 years. Actually, we have 3-year data now showing that the group that received 20 minutes of stimulation twice a day had phenomenal results. Now, why is that interesting? Well, because if it's only 20 minutes twice a day, we might be able to put a small chip under the skin that's activated externally. There may not even be a need for a permanent long-term device that actually has all the internal workings. So I think that's pretty impressive. We followed this up with this study. You may have this, I'm not sure if you have this yet in your part of the world, but we have a small lead that's really a new concept. It's a monopolar lead that's very small. And I just did this work with Chris Gilmore and other colleagues. We stimulate the nerve for 6 hours a day for 60 days with a totally externalized system. There's nothing inside the body but that small wire over the L4 nerve. And we then remove the leads under general traction after that time. Here's a look at how small that wire is. You see there compared to a quarter, very, very small. And we can put the lead at L2, L3, L4, or L5 based on the patient's pain pattern. And the goal there, much like the permanent device I showed you for the multifidus study, Reactivate, here is just to see in some patients who've had injuries, we may not need a permanent device. 60 days may be enough time to change the course of their spine so they do well. And so that's part of PNS, peripheral nerve stimulation. And I want to, this is the last part of my talk, but PNS has really evolved. When I started doing PNS years ago, we put a spinal cord stimulator around your nerve in your head. It was crazy. And we were doing that until a few years ago. I did the first randomized study in America we published in 2010 that led to FDA approval of something called a stim router. And that was really the first totally internalized device that was used widely. But now we're going to try to find new concepts. And so we really found that, again, here's a look at our peripheral nerve paper I just showed you. 60 days led to long-term improvement here up to 6 months for pain, ODI, and pain interference. So we actually, why did a therapy for 60 days help someone after it's removed? That was a question we tried to answer. So we now just published this paper. And if you go and look at any of my social media, I have a link to this paper. This is Journal of Pain Research. Sam Aldabi, I think, is the second author with me from Britain. We looked at why can we change things after 60 days? But for example, I do a lot of median nerve injury patients, and I'll put a lead in there for 60 days, and I don't have to put a spinal cord stimulator in because they get back to normal. And our theory is we're changing the brain over that time. And here's a look at 13-month data on PNS after medial branch nerve stimulation, for example. So we think actually what we're doing is changing the cortex by having this lead close to the nerve. So if you think about chronic old-fashioned peripheral nerve stimulation, you would only stimulate the pain pattern. So only a little bit of the nerve in the brain would change, the pain fibers only. And that's why when you put a PNS system in normally and you turn it off, the person's pain comes right back. If you do a trial of PNS usually, and you take it out, the person's pain comes right back. So what's different about this? Well, this is a monopolar lead that actually stimulates more fibers in the nerve. And it sends a much more dense signal to the cortical input. So it's focal to the area of the pain. For example, you have an ulnar nerve injury. It's focal, but it's also robust. So that signal is going to go to the brain and change the way the brain cortex functions at the level of the nerve injury. So that's our proposed mechanism. We just published that paper. Now, this is the last thing I want to say, and it's about MRI. So I just showed you a lot of cool things. And again, I apologize. We only have 30 minutes to cover 1,000 things, but we also need to keep working towards MRI. And the reason that is because some devices have had great MRI capabilities, but they aren't very good and they get explanted because they don't work. Other devices have had great functional ability, but they don't have any MRI capability. So they get explanted because there's no MRI capability. So I have challenged all the manufacturers. We need great devices that work, that can have an MRI under all conditions. And so this is a paper we just published in Neuromodulation about, I think, 2 months ago. Well, actually 3 or 4 months ago now. And so I encourage you to read that paper. But our main thing here is we have to drive the manufacturer to do a better job of giving us both. Because they always tell us we have to choose between MRI capability and more functions for our patient. We need both. So I think we're getting to the era where we can do that. What's the future? Virtual clinic. I just programmed the first 2 patients in the United States virtually. We're involved in the first launch program of one of the manufacturers getting approval. So they can be at their house. I can be in my office and we can program their device. This is so really important for international physicians, because you may have a patient who lives in Dubai and you may reside in Saudi Arabia, for example, and you may not have trouble seeing someone very easily. So this is going to let us see them from their home, talk to each other like we would on telehealth, remotely program their device. We can see their device on our computer screen and make changes. The other things that are the future is long-term outcome tracking, real-world registry data, paddle DRG, and then mini PNS. So I think we're going to get to where PNS's peripheral nerve stimulators the batteries are the size of a coin and really can last for several years. So those are some of the things I see coming forward. So we got to get off the beach. I showed you that first slide. I'm right at 30 minutes right now. We're on that beach looking at all the stuff out there. And we were scared to get off the beach. But now we got to get off the beach and we got to advance things together. And with that, I think I have 10 minutes for questions. So I'll give it back to my colleagues, the moderators. Thank you very much.
Amazing talk, Tim, and thank you so much. And just to piggyback on to your point, when I was in fellowship back in Cleveland Clinic in 2010, 2011, as my mentor, Dr. Nagy Mikhail, used to say, if you get 50% of the patient improved by 50%, that's the goal. And at that time, there was only 3 companies and it was just the same thing. And I felt the field was stagnant. And it's amazing when I start to practice over the last 8 years or 9 years, things have evolved in the neuromodulation field. So a quick question for you, Dr. Deer. So in terms of my experience, we're lucky to have our first center to do DRG in the Middle East. And is there any newer designs or things to prevent lead migration going forward? And what's your tips regarding that?
Yeah, so those of you who haven't done dorsal ganglion stimulation yet, once you get good at it, it's my favorite procedure. But you have to be a student of the game. And Rita, I think you'll agree with me. You have to get really good with the sheath. You have to get really good at making the loop. So if you look at migration, the most common reason for migration is one of 2 things. One is the loop doesn't go up first. The loop has to go up first and then back down around. If it goes down first, it will pull the lead out over time. 2 is there's been a lot of debate about, do you anchor or do you not anchor? There's been a lot of debate about that. I just published a paper. Well, I think it's been accepted but not published yet in regional anesthesia pain medicine. It's been accepted with revision. But with Ken Chapman, Dr. Callaward, Tim Lubenow from Chicago, and I anchor, and some of the other folks don't anchor. And what we showed was anchoring is a better idea. It's better to anchor than not anchor. So I think that's the 2 things to lower migration. There is a new lead coming, a new sheath coming. I think that'll help too. But I think right now it's upward loop, and then I think you anchor with a stream relief there as well.
Perfect. And you have a questions. There is so many questions here, but there is a good question that actually is very relevant to our practice as well. What's your experience in patient with spinal cord injury, neuromodulation for those patients?
So, I think for me, it all changed with, and again, it depends on what you like in your practice, whether it be high frequency or burst. I prefer burst in my patients for the most part, but it all changed after that came out. Before we had a waveform that would work more centrally, I have a lot of spinal cord injury patients sent to me for pumps, for baclofen and other things. And I would try stimulation on those patients and it would usually fail. But like I have a case scheduled next week when I get back to West Virginia, where we're going to go in at T1, 2 or 2, 3 and put burst leads in. This is a person that's got an injury at the T4 level of their cord, and they're not totally paraplegic, but they have a lot of nerve pain in their body. And I've seen some success, but I do 2 things. I let the trial last 14 days, longer than normal in those patients. And sometimes I'm even tunneled the trial out for 30 days to give them time to see if it's going to make a difference. I think overall, you'll still have about I think we've joined the 80% success club for most of our patients. I think that's going to still be 50-50, Reed. I think half of our patients will fail. Sure. It's worth it, but you can't use a tonic waveform. You have to use something else.
Sure. And we had other questions here, just looking at the chat here. There is a question about what's the complication that happened at the C2 dorsal root ganglion stimulation.
So there was a report out of Australia of somebody that did a C2 DRG without neuromonitoring in a sleep patient and had a cord injury. If you're going to do anything in the DRG or anything else in the cervical spine, the patient should either be wide awake, able to talk to you because tell you they have a paresthesia, or they should be asleep with neuromonitoring like you would do for spinal surgery. That's what I do for DRG or any complicated cervical case. If you do it, someone who's too drowsy anywhere in the spine and they're asleep, they can't tell you if they get a paresthesia or an injury, then that's really going to cause injury. So I think that was more of an anesthetic complication. They had the person too sleepy and the person couldn't talk to the physician. And again, that led to some anxiety about going above C5. And I don't generally go above C5. There's a lot of crosstalk up there. I see C6, C7, T1 usually gets most of the upper extremity. So I haven't really found a need to go that high at this point anyway.
There is another question talking about they're asking for L2 DRG stimulation for chronic axial back pain and difference between high frequency bursts and conventional. I think that's pretty obvious. For L2 DRG, we don't use high frequency stimulation. Any thoughts on that? It's just
I'll just comment on that right now. So far, most DRG at either T12, which is what Dr. Chapman's done a lot of patients on, or L2, Dr. Calaward's version, we've seen good axial back success. That's with a subthreshold tonic waveform, because remember, I showed you the T-cell junction. You usually only need a bipole to get that. You don't need a complicated program. But we are going to start bursting the DRG. That'll be, right now, there's no high frequency of the DRG. There's no evidence that would work. In fact, it would kind of scare me to put high frequency on the DRG because it may heat the DRG. But I think bursting the DRG is a research project I'm working on currently with people like Kiran Patel for pelvic pain. She's working here with me to discuss some of those protocols. So I think we are going to get that done. And will it make any difference? I don't know. Maybe we'll find out. I just can't tell you right now. I have no clue at all. I don't know.
Another question also that's from myself. What do you see the role of DRG in patients like with diabetic neuropathy? Since we encounter a lot of those patients in our practice, and anecdotally, I've been having very good results so far, but I don't have enough sample size yet.
Yeah, I'll tell you, in America, my bias is that the number one indication is neuropathy. Because if I talk to all my colleagues, I think they're using DRG more and more for neuropathy, and they're having great results. And that's really some of the first patient ever done in America I did at a failed knee surgery with pain after knee pain. But neuropathy, we put S1 for the feet and the toes, and then L4 or L5 for the other part of the leg. And we've seen that work real well. I will tell you, I think what's going to be the biggest thing for DRG in 3 or 4 years, that's why everyone probably should learn to do it. We're doing work right now. The animal model is very, very exact, and it's been done at people like up at the University of Wisconsin, where they do a lot of great lab studies. It looks like it works really well for nociceptive joint pain. And with all the aging of the population around the world, I think that's probably going to be the next big study we do is DRG for hip and knee pain, arthritic conditions. And I never dreamed that would work, but the animal model shows it may work better than even nerve injury, which is that may explain why it helps at the axial back at L2 or T12, right? So I think that is the future of DRG is nociceptive joint pain, probably.
Perfect. I think in terms of time, let me see, there's a question about, it's not necessarily related to the talk, but about the difference between discogenic and vertebrogenic back pain.
Well, we got new things going on in America. We got approval for some new stem cells. Stem cells have been mostly quackery up until now. People doing all kind of crazy things. But now the FDA is going to come up with approving 2 different lines of FDA studied. I was involved in one of those studies. So I think that may change discogenic pain. And there's some new techniques of going in and heating, the basovertebral nerve inside the bone. And that just got FDA approval. I don't know if it's going to work yet or not, to be honest with you. And I don't know which of those modic changes we're going to actually treat. But our practice is going to adopt that therapy and see. We like to offer anything that's FDA approved to our patients, and then we like to study who it works in. So I do think discogenic versus vertebral pain is important, but we don't have a great way to identify which is which, other than things like discography, which is really unreliable. I've done thousands of them over the years. Pretty unreliable, though. That's why we don't know, really. So I wish I could answer that question, Rita. I don't think there is an answer to that question.
No, there is no answer. And
Holy Grail. I don't think we're gonna find the answer for that. But right, Reda.
And I think we're gonna go just one more question. Also, I think it's very relevant to the audience, and I saw a question related. What do you see the future for in terms of PNS, like the work you did with Chris Gilmore about PNS of the multifidus muscle, and in terms of versus radiofrequency ablation? Same concept also for example, SI joint denervation versus stimulating the lateral branches. What do you see in terms of the algorithm where this should fall in?
Okay, that was a lot of stuff. So let me, this will be my last question. So I'm going to answer it slowly and tell you what I think. So let's start with the SI joint. People have stimulated the SI joint. I think that's crazy. There's no data that that's a good idea. People put PNS leads over the joint. I think most of those are eventually explanted. I think stimulation for SI joint pain is a terrible idea until proven otherwise. And so I think that's a poor choice of patient. I wouldn't recommend it to anyone to do that unless someone comes up with a study that shows where to do it and how to do it. No one's done that so far. SI joint ablation, we've had pretty good success with that. We do about probably 10 a week in our clinic. We've used things like the wand, the Simplicity wand. We've used multiple burns. We've used tripolar burns. The thing about SI joint ablation is no one's really told us yet the best method to do it. That's the problem with SI joint ablation. You can talk to 4 different doctors, all of whom are convinced they're right. No one of whom may be right. We just don't know. There's not any studies. We're doing a lot of posterior approach SI fusion now, which is much less invasive than the lateral approach that surgeons do. They don't like the fact that we're doing it through the posterior approach because it's a different technique, but it is less risky. There's no sciatic nerve, there's no vessel. So I would say the future of SI joint pain is going to be if we're sure it's a joint, is going to be posterior fusion with a fixation device because it's so simple and so much less expensive than the lateral approach. The other thing you asked me, RFA versus multifidus stimulation. If RFA works, I think we're going to keep doing that because, we have a lot of patients, we repeat it once a year for years and they do wonderfully. It's when they fail the medial branch block or when they fail RFA, it doesn't last 6 months or longer. Then I think a progression to a more permanent treatment like PNS is going to be wise. The other thing, some people feel that the 60-day therapy is really good for young people instead of ablation because ablation may lead to multifidus muscle atrophy. And so if someone's under the age of, say, 35, you may want to consider doing a 60-day PNS, and then if it doesn't work, going to RF. But if they're over 35, I tend to go to RF first and only go to PNS if it fails.
Okay. Thank you so much. Thank you.
Thank you so much, Tim.
Great.
Really appreciate it. That was fantastic. I think quite enlightening talk, and really appreciate you, giving us your time early as a morning there. And I know you have to jump on another meeting, but really appreciate it. Thank you so much.
Thanks for having me, everyone. Have a wonderful day and
so much
night.
Okay.
Bye-bye.
Thank you so much. Bye-bye.
See you soon. See you.
Bye. See you soon. Absolutely.
So now we're going to move to a dear colleague of mine. Dr. Leonardo Caporal is not only a friend, but he was a mentor to me when I was a resident. I actually did my first publication with him on differential epidural block. I don't know if he remembers or not, but I was a CE2 trying to get into fellowship. And Dr. Caporal is not only just a pain physician and educator, is also a scientist. He's almost involved in most of the studies going on in the field of neuromodulation and other fields in neuroscience. He's a dear colleague of mine. I was lucky enough to also, after being mentored by him in Cleveland Clinic, later on we meet and work together at Wake Forest University. Dr. Leo Caporal is a director at large in the North American Neuromodulation Society. He has a lot of titles. He's a professor at Wake Forest University, and he has contributed tremendously in the different society, including the INS, the NANS, the ASRA. And with great pleasure and honor, I'd like to welcome, and without further ado, Dr. Leo Caporal, our famous speaker today.
And
thank you. Thank you, Rita. Very much so.
Thank you. Rita, the secret is Leo is a great DJ, by the way. First I met Leo in Croatia. And I told him, Leo, you need to teach me DJing because I would like to do that. So, Leo, thank you so much for coming and giving us your time for Gulf Pain School. Really appreciate it. Thank you.
Thank you, Amar and Sadiq and Rita. You guys did a phenomenal job, and this is such a nice occasion, to get out from. I'm originally from south of Croatia, and I like to be involved in lots of European, Middle East, and other events because I think it's also bringing these new therapies and sharing with the colleagues across the world. As far as the DJing, yeah, I have a setup. We are doing a parties. We play in our last meeting, so anytime, In my previous life, I did professional this for short time. Yeah. So anyway, Tim got the nice introduction, and I think it's also I'm going to pass on some of the things that Tim details, like DRG and Evoke. I'm going to give just a little overview on it. I was fortunate to be involved in most of these studies and led quite a few of them. So I'll give you my perspective on it. And let me just go to the full slide share. I hope all of you see the slides and you can hear me well.
Yes. Oh, good.
Very good. Very good. So these are some of the conflicts of interest related again to the number of the studies that we do in our place. We have a very large facility here in Winston-Salem, North Carolina. We run about 30 to 35 studies at a time at our Center for Clinical Research. And we also do very large amount of the neuromodulation studies, including competitive grants like the one that we had from European Union. So I'm really pleased that this is the basis for what we do as far as the giving information out. So what is new and what are we doing when it comes to lower back pain? Well, we had a landmark study that changed this, what Rida called 50-50 club. Nagy Mikhail called 50-50 club initially. For 30 years, we were using traditional low frequency above the threshold type of spinal cord stimulation where we were able to achieve about 40 to 50% of the patients with more than 50% of the pain relief. And that time is gone. And we actually improved very much in therapy. DRG stimulation showed 80% of the patients with more than 50% of the pain relief, but in mononeuropathy, and it still needs to have a randomized prospective study to prove that it's as effective for discogenic back pain. What else is new? Burst stimulation is somewhat better than traditional spinal cord stimulation. There's some new remote leads like from Nalu and StimWave that are kind of started this new trend of not implanting the battery in the body. I think that the technology is still, it's good, it's getting better, but we still need to work on it. And then ECAPS, closed loop spinal cord stimulation, I was really fortunate to start with them very early, 8-9 years ago. We did a temporary trials here in Winston-Salem, North Carolina. It's a great invention. I'll talk about it. The improvements in the pain scores were profound and maintained over extended time periods. So they are so with 10 kilohertz, this is a second therapy that belongs to that 80% of the patients with more than 50% of the pain relief club. And the third one will be glial cell stimulation, or what they call DTM stimulation. This is invention from small company Stimgenics, of colleague of ours, Ricardo Vallejo, that progressed into full randomized prospective studies. Now, the therapy is owned by Medtronic, which is advancing this therapy further, and 12 months data were presented at the North American Neuromodulation Society meeting just a few months ago, and they're looking really good, and they belong to that 80% club. So now we have also ultra high frequency. We're starting next month this study. This is 500,000 hertz stimulation from small company, which is called Jimmer Medical from Taiwan. I was honored to be, again, principal investigator for a whole country. And I think it's going to be very interesting because you need only 5 minutes of the stimulation to achieve 5 to 6 days of pain relief and does not require implantation of the battery. I'm not going to touch on multifidus stimulation because Tim kind of detailed this. So also, not only new technologies, but new indications for lower back pain are being built, evidence is being built right now. Non-surgical refractory low back pain is ongoing study. I'm the PI, and it's funded again by Nevro, 10,000 hertz, which show the best benefits for back pain over the last 6 years. Non-surgical refractory back pain are those patients who are not the candidates for surgery as determined by the surgeon. Also, we have other, like Medtronic, Abbott, and Boston Scientific are doing virgin back pain as this sort of alternative to a surgery. And those are ongoing trials which did not report data, or they're just at the beginning right now. So, and again, multifidus stimulation, as Tim nicely detailed, possibly making multifidus muscles stronger. Although I always doubt how much incentive patient has if they don't do their physical therapy. Our main approach for multifidus, muscle is a physical therapy, and investment from the patient has to be followed by investment from us. So again, I mentioned outcomes: conventional 0 to 1200 hertz stimulation provided in about less than 50% of the patients, more than 50% of the pain relief. Breast stimulation is somewhat better. Actually, Dr. Deer, who just presented the data, she showed in a Sunburst study that is somewhat better than traditional spinal cord stimulation. But then you have three therapies that I mentioned before: 10 kilohertz and DTM and closed loop stimulation that exceeds 80% of the patients with more than 50% of the pain relief, and established a new benchmark when it comes to the spinal cord stimulation and success. So I'm going to detail those three as the main therapies for lower back pain when it comes to neuromodulation and spinal cord stimulation. So this is a census study that sort of started over. We only had two prospective randomized studies in 30 years before that. And this was North study back in 2005 and Kumar study back in 2008. And both of these studies showed great benefit of the spinal cord stimulation of traditional type. The problem with the spinal cord stimulation of traditional type is that the improvements at the trial, that about 80%, are not maintained over extended time period. So they go down to about 40, 50% that are maintained over the extended time period. And we showed that in comparison study, head-to-head study, there was just recently, 5 years ago, published. So these are the back pain data and 24 months follow-up with the 10,000 hertz versus traditional type of spinal cord stimulation. And you can see that improvements in the back pain were superior when it comes to 10 kilohertz subthreshold type of stimulation. And that can be explained easily with the additional mechanism of action that 10 kilohertz spinal cord stimulation provides. If you look at the basic science data from article published in Neuroscience, which is one of the highest impact factor journals in a neuroscience world, is that we can recruit much better dorsal horn in addition to dorsal column when it comes to 10 kilohertz. And that's the main mechanism. It's the direct effect on the projecting fibers from laminas 1 and 5 that have direct inhibitory effect on wide dynamic range neurons in a spinal cord, and that way decrease what we call central sensitization process. So the leg pain was similarly better when it comes to 10 kilohertz type of spinal cord stimulation. And then the 10 kilohertz was also shown to be superior to traditional spinal cord stimulation when it comes to improvements in functional capacity. So you can see that most of the patients with 10 kilohertz went to from the severely disabled to moderately or minimally disabled. And this was superior to traditional type of low frequency spinal cord stimulation. So now what we embark on is to go the next step with 10 kilohertz spinal cord stimulation and to look into this type of stimulation for those patients who are not the candidates for the surgery. And this is design of the study, and because it was pragmatic and interesting for reviewers and editor, it was already published. Only methods, design of the study, I think was well done, and that's why it was published in Pain Practice before we actually embark on enrollment of the patient. Now we do have a data, and I'm going to tell you a little bit about it. So first of all, I want to make sure that you understand who are the patients with non-surgical refractory back pain. So those are the patients that were told by the surgeon they are not candidates for the surgery, but they have intractable, severe back pain. And then this pain is resistant to any of the conventional medical management and interventions. That includes injections, transforaminal epidural injections, include radiofrequency ablation, include physical therapy, bracing, and all kinds of other interventions that on top of it include opiates and membrane stabilizers like anti-seizure medicines, gabapentin and pregabalin that we use for some of these patients. So this is a study design. As you can see, the randomization process was taking place where we either randomized patients to conventional medical management or 10 kilohertz type of spinal cord stimulation. We enrolled 216 patients, mainly who are not the candidates for back surgery, no previous back surgery, and back pain of more than 5. So primary endpoint was 3 months, and we are following patients now beyond 3 months. I reported as a breakthrough session at the North American Neuromodulation Society a few months ago, the initial data at 3 months, and we're going to also be reporting on 1 year, 2 years, and 3 years afterwards. So, so some of these, and then we have a crossover phase where we're going to basically look at the patients who switch from the conventional medical management to 10 kilohertz or vice versa. So these are some of the results. So in pre-specified analysis, via the power to meet the primary endpoint, so enrollment was stopped and at 211, we randomized 159 patients. And then we went on and randomized in 2 groups of about 80 in each side. As you can see, we were happy that we were able to, most of the patients to follow through the 3 months primary endpoint on both sides. And then what we did, basically, we look at the demographics and you can see that we are very pleased how the patients were randomized in 2 groups. We were fortunate to see balanced groups of 2 balanced groups where age was similar, years of chronic pain similar, and then causes of back pain were similar too in both groups. And you can see that this is a mixed bag of the back pain causes, including degenerative disc disease or discogenic pain, like Tim Deere mentioned before, spondylosis, radiculopathy, spinal stenosis, and then even adding cytokine and sacroiliac dysfunction. So primary endpoint was superiority shown to those who received 10 kilohertz and conventional medical management versus those who only received conventional medical management. We have only 1 patient who actually improved. Improvements of the pain scores from 7.5 to 1.9. At the primary endpoint, again, we are following same thing as we did in a census study for those patients who had the previous surgery. And again, up to now seems to be comparable to those patients when it comes to those who did not receive a surgery. So as you remember, we were able to achieve about 80% of the patients with more than 50% of the pain relief in that census study, as I showed at the beginning of my presentation. So you can see these are individual patients who received the therapy. On the left side, when we used 10 kilohertz, obviously there was majority of the patients who improved, even with more than 50% of the pain relief. But then if you look at the subpopulation of the patients who were what we call profound responders, those who achieved more than 80% of the pain relief, there were about more than half of them. So this is pretty good achievement when it comes to back pain, where we had always struggled when it comes to the neuromodulation and spinal cord stimulation. And this really tell us that there is a place of the spinal cord stimulation when it comes to treatment of the back pain, choosing a proper waveforms. So, and then improvements in disability when it comes to improvements in a functional capacity, again, from severe disability to moderate and minimum disability, most of the patients went to either moderate to minimum disability when it comes to 10 kilohertz, and patient satisfaction as measured by global impression of change was on the side of 10 kilohertz plus conventional stimulation. So in order for us, and this is also majority of the patients with the back pain who had the previous surgery, we look into if when we have a traditional spinal stimulation that is failing or already failed. So those are the patients who had their traditional spinal stimulation implanted, and they failed after a couple of years. The stimulation, what they call, doesn't work anymore, or they turn off their stimulator, or they say, well, I'm not getting much of the pain relief. I need some more pain medicine. So those patients were switched from traditional low frequency type of the stimulation to 10 kilohertz. This was done in conjunction between two centers. It's University of Kansas, the medical center. University of Kansas is one of the sites of excellence with Dawood Sayed and his group around him, who are leaders in education and studies when it comes to interventional pain management. And so, as you can see, we extracted the data on the switch-offs that we did. This study was actually initiated by the patients. When the 10 kilohertz was approved by FDA and labeled as superior treatment to traditional spinal stimulation by the FDA, in May of 2015, there were some patients who started calling. One of the patients was a lady who was the director of a large nonprofit organization across the U.S. So she was traveling a lot, and she has severe back pain. She had a previous surgery and maintained severe back pain after she got a traditional type of spinal stimulation implanted by a colleague of mine at the University of Washington. So patient was basically sent to me by my colleague, Michael Gofield, who was at the time in Seattle, to look at the option maybe to get in a study. And as we finished the study and we were just got FDA approval, we decided to just switch the system to 10 kilohertz. And from no improvements, because she turned off her stimulator 6 months before, to 80% of the pain eliminated. It was so refreshing to me as an idea to try in some of the other patients who failed traditional type of the spinal stimulation. So this is what we did. So these are some of the characteristics of our patients. As you can see, they maintain relatively large amount of opioid usage, and then they were also mostly with the failed back surgery syndrome, so they had a previous surgery. As you can see, before the switch, their patient scores were maintained at about 8, and we were able to decrease it down to about 3 in the patient who already failed traditional spinal stimulation. So these data are very interesting to say, okay, well, what to do as a rescue therapy after you see the traditional type of spinal stimulation failing. As you can see, this tornado chart again, almost every single patient improved except a few down at the bottom. In 85 out of 105 patients, so 81% of the patients improved with more than 50% of the pain relief as a rescue therapy. So very potent type of the therapy that can provide rescue from failed traditional type of spinal stimulation. Again, improvements in opioid usage after such a switch were profound as well. Tim was talking about ECAP, electrical evoked compound action potential and closed loop type of spinal stimulation, which is a great invention by John Parker, really phenomenal physicist and scientist from Sydney, Australia. I got connected with him relatively early, and I was fortunate that I did. So it's based on the direct stimulation to the dorsal column and recording back evoke compound action potentials as the physiological marker for the proper adjustment within a therapeutic range of this type of spinal stimulation. And Tim showed you this little recording, and this was actually patient number 003, which was our initial patient of mine, actually, that was recorded here in Winston-Salem, North Carolina. this is the same patient, 0301, who, when we use traditional type of spinal cord stimulation without activation of the closed loop, was subtherapeutic most of the time. And what happens, you see, if they feel paresthesia and the patient moves around, they basically, if they feel a surge of the stimulation, let's say when they lay down or position themselves horizontally, then they would decrease the amplitude of the stimulation. And many times, because they change position so many times during the day, will not readjust, and they will maintain subtherapeutic stimulation that really does not deliver what we're supposed to get when it comes to spinal cord stimulation. And all of these 72 different mechanisms of action of spinal cord stimulation that includes increase of the GABA, increase of the glycine, decrease of the glutamate, improvements in nitric oxide on periphery, increase of CGRP, and so on, will not happen if they are within the subtherapeutic range. So if you use closed loop type of the stimulation and adjust proper adjustment of the ECAPs, they end up in therapeutic range 24 hours a day, most of the day, and maintain minimal type of paresthesia. So we were fortunate to be the number one, meaning first implant in a Evoke study. The team detailed the study, so I'm not going to. But these are the patients, again, with the back and leg pain. And again, similarly, like 10 kilohertz, the profound relief of the pain was achieved. And what was different in this spinal cord activation is that in a closed loop type of the stimulation, the maintenance of the ECAP stimuli at the maximum level, the centralized in a position that we wanted to be, was in most of the patients as opposed to open loop type of stimulation. And then also maintaining therapeutic window because of that was predominant or almost all the time when it comes to the closed loop type of the stimulation. And then again, this followed improvements in the pain scores that were better, much better in a closed loop type of the stimulation, with 82% of the patients maintaining more than 50% of the pain relief at 3 months and 83% of the patients at 12 months. And the Nagy Mikhail, who is the first author on the study that we published in Lancet just last year, is preparing now in 24 months data and to show the longevity of the pain relief using this type of closed loop stimulation. Again, improvements in functional capacity followed. Also, with 3 disability index, you can see that the improvements were profound when it comes to functional capacity, sleep, and emotional function. Again, opioid reduction was also, although not intended, so it was, if you look at the improvement, it was still there from 54% to 40%, so it was quite a bit of the improvement, even if you compare to traditional type of stimulation. Again, I'm going to talk about DTM because Tim didn't touch on it. But I think this is very important type of the stimulation. I was very early consultant. I was helping at that time Ricardo Vallejo to initiate the studies, and I think that the idea is just phenomenal because if you have a waveform that provides different pulse signals intended for different cell types, you may be able to recruit not only neurons, but also you can recruit glial cells. And what's about glial cells? Well, they are in abundance at the T8, T9 level, the sweet spot that we always stimulate for spinal cord stimulation. Glial cells outnumber neurons by 12 to 1, and even more when it comes to difference between gray matter and white matter. So most of the effects that we are able to achieve applies to 2 groups of the glial cells, microglial and astrocytes. So those cells interact closely with the neurons. They are electrically active. They change the threshold for activation of the neurons, and they're very, very legitimate targets. We know that from the past. These are some of the animal studies. I'm not going to talk about this past effects and the achievements that were done in the basic science when it comes to the stimulation of the glial cells. But let me talk about the recent data from Vallejo's lab. First of all, if you look at the model of neuropathic pain, you can see that the DTM provides better improvements to the normal than low frequency and high frequency type of spinal cord stimulation. So he called low frequency, high frequency something between 40 and 90 versus 1000 hertz. So this is still belonging to that conventional type of the spinal cord stimulation, but as you can see, the DTM provided better improvements of mechanical hypersensitivity in rats. And then also, which is really important, as you can see, modulation of some relevant biological processes. And this is, he was looking at the messenger RNA expression of the genes related to inflammatory responses, but also neuropathic responses in the human body. And as you can see also that improvements were profound and better when it comes to DTM versus low frequency or high frequency type of the stimulation. Again, this prompt Stimgenics and then later Medtronic to initiate a randomized prospective study. Again, conventional type of spinal cord stimulation against DTM following it for 12 months. Again, groups are well balanced. As you can see, many years, 13 years of chronic pain in average. And then those patients typically had a previous surgery. And again, if you look at the improvements, when it comes to conventional type of spinal cord stimulation, about 50% of the patients, more than 50% of the pain relief at 3 months. Now, Michael Fishman just presented 12 months data, and they're almost identical. So what you're seeing here at 3 months actually was presented at 12 months just now at the NES. But 80% of the patients had more than 50% of the pain relief in a DTM arm of the study, suggesting that you can achieve much better pain relief when it comes to the DTM. Again, this is another tornado chart, and I love in these randomized prospective studies, which is our level 1 evidence, to see every single patient as so really nicely show those all of the results up on a table and show how much improvement in each and every single patient happened. And as you can see, when it comes to low back pain responders, that DTM does provide that profound relief, with 63% of the patients being labeled as profound responders to DTM, with more than 80% of the pain relief, which is really impressive. So DTM is here to stay. I think we are looking to see more data. We are obviously looking forward to see longevity of the therapy beyond 12 months and see if you have such a system that is getting implanted in the body. I think those studies, like I show you with 10 kilohertz and Evoke study and DTM with 24 months or longer data in a prospective randomized fashion are key to maintain our relationship with the patient, but also with the payers. And again, if you look at the leg pain, improvements same like in the back pain, were profound when it comes to the DTM. So in conclusion, and I'm going to stop here. 10 kilohertz spinal cord stimulation, same as the closed loop type of the stimulation in DTM, provided in more than 80% of the patients, more than 50% of the pain relief. When it comes to burst type of stimulation, maintains better pain relief than traditional type of spinal cord stimulation. When it comes to ultra high stimulation, it seems to be promising, and we're still looking forward to see. I have to mention there are several other very interesting bidirectional waveforms. The one that I'm working on right now is with a large German company called Biotronic, and they are pioneers in remote programming, but also they're pioneers in very detailed basic science when it comes to spinal cord stimulation, where they produce this new type of the waveform that is gonna be shown in so many future articles. We finished 184 patients randomized prospective trial just now. I was also fortunate to lead that study. It looks really good. It's acute study or 3 weeks. So we are looking forward now to see the prospective randomized study that is going on for minimum follow-up of 2 years. Similarly, that 10 kilohertz closed loop and DTM stimulation showed in the past. So we are very pleased with the spinal cord stimulation for chronic low back pain. First of all, because complication rate is all-time low. Cost is still high, but if you look at the cost effectiveness, it breaks even now, even before 1 year of the therapy. The medications are expensive. I mean, you see the patients going off the medications, that's where you see the great cost effectiveness, decreased number of the visits to the office, decreased number of visits to the emergency room, improvements in decrease of the imaging, and again, profound decrease in opiates and membrane stabilizer usage. So the main thing is here careful patient selection, obviously. We really want to make sure that these patients have psychological evaluation for implantable devices, they're proper candidates, they're properly assessed by the physician, and do not have complicating issues that will cause much of the problems like immune responses, severe uncontrolled diabetes, where you can get into the problems of infections when it comes to this therapy. So thank you very much, and I would take any questions.
Amazing talk, Leo, as usual. I think you brought up very important points and covered pretty much everything in terms of technologies. And I have a question for you. Seeing the future of closed loop technology, do you see all companies eventually adopting this? And how long do you think this will going to take?
You are right on a target. I would say probably, as you know, and Rita knows about that quite a bit from, he was here in Winston-Salem at the Cleveland Clinic for years, and we had a whole lot of discussions about it. But yes, I believe that most of the companies will have certain type of closed loop stimulation within the next 5 years, and I think that's a really good new next step. Disregarding the waveform they're using now. The question is how to maintain closed loop with a certain waveforms. When it comes to very high frequencies, that's very difficult. When it comes to subthreshold type of the stimulation, it gets a little bit more tricky. But I think there's a phenomenal work happening. Medtronic presented data on their closed loop, and the others are grabbing that way very fast. So let's see what happens. I think it's a very good development. I think it definitely closed loop is the one that maintains the therapeutic range all the time, disregarding what kind of waveform you're using. And the number two, even more, this can be even more advanced, or it can become more sophisticated. They have a new wave of the devices from Saluda from Australia, those pioneers with the Vogue study that already presented phenomenal data. So how far we can go? And Max is smiling. I can see on his face. Can we reach more than 90%? I don't know. We always have patients who have, issues with other chronic pains, secondary other problem, dependency on the medication. So if you take that small population out, how far you can go when it comes to improvements in the pain scores? Really, I think we are reaching that ceiling already. We are getting there with these 3 therapies with 80% of the patients, more than 50% of pain relief. Maybe we can go a little better.
Thank you so much for the answer, Leo, to the point. And we have a question from the audience about, I think, development of adhesions or fibrosis around the leads, and if that can affect the efficacy of the therapy.
So if you look at those patients that were implanted 20, 30 years ago, even with the leads that were not as perfect as we have right now, we don't see quite a bit of the development of the adhesions in epidural space. That really is not an issue. Impedance changes, maybe sometimes, in some of them who develop small thickening around the electrodes, but keep in mind, we did so many replacements after so many years. Let's say I did the other day somebody who I replaced after 15 years having leads in epidural space, and those go easily out without any problems. There is no really an issue of any major adhesions. Well, yes, if you have paddle leads, that's a different story. Paddle leads are much more destructive. Obviously, that's so to the dura. With these waveforms that we have right now, I would say I don't see the role of the paddle leads unless you have instability, unless you have migration of the leads and you really need to sew them to the dura. So if you need a vision of traditional percutaneous leads, I would say then you can go with the paddle leads. Okay, so those are surgically laminotomy implanted leads that really are not the first choice. So with the percutaneous lead placements, I see this as a no issue at all.
Perfect. So speaking of DTM, and we've done a few cases here in Cleveland Clinic Abu Dhabi in Medtronic DTM. And do you suggest to start with DTM right away during the trial and make it, or do you consider doing tonic or alternating tonic and high density, or what's your decision in that?
So, I mean, I think we went a long way over the last 5 years thanks to Never and 10 kilohertz, because we do now these seamless, like 5-minute trials that we place the leads to the epidural space without any testing. Except obviously Saluda closed loop, because you still have to sort of spend the time during the trial to place those leads in a perfect ECAPS lead placement. But when it comes to DTM, I start with the DTM from the beginning. I think that the patients do have profound relief, better than with traditional spinal cord stimulation. Same as we did with the 10 kilohertz with Dawood Sayed and a group at the University of Kansas with the 10 kilohertz when we did the rescue study in 120 patients. Now we are doing a rescue study with the DTM. And I tell you, it's pretty impressive, maybe even comparable. So I'm very optimistic, and definitely I advise to start with the DTM as I do when I use the DTM for my practice.
Thanks, Leo. And we have a long question here. I'll try to summarize it. They're talking about regarding selection criteria for the study on back pain. I'm not sure which study, but I think one of them, the selection criteria seems very broad: neuropathic and nociceptive pain arising from anterior posterior elements. Can you explain the probable why we have such diverse pathologies and good response despite having different pathologies and different types of pain? I guess that's
because this is the real life. Yeah. If you have a failed back surgery syndrome, you have influence of 25% of the patients with sacroiliac joint pain, another 20% of the patients with facet problems, and so really you cannot, you do help those patients. You see, when we use traditional spinal cord stimulation, even now when we use these advanced therapies, we still do additional treatments, repeat that radiofrequency ablation of the facets, because this is predominantly inflammatory pain and lots of nociceptive pain. So yes, but keep in mind, payers and everyone else is asking to have real-life patients who may have predominantly neuropathic pain, but they have other components of the pain in their back. That's why back is so complex issue, and that's why we had such lousy results when it comes to traditional spinal cord stimulation. But look at now 10 kilohertz, look at the improvements. Definitely, if you look at the mix of these patients, definitely there is additional effect to nociceptive pain. And I think that has everything to do with mechanism of action. Just read that paper in neuroscience about the additional effect to the dorsal horn. So now you can affect the dorsal columns and dorsal horn with 10,000 hertz. With the DTM is more regional effect, but it regrows the glial cells. And I think that's another key reason why. And then with the closed loop, The reason is because the closed loop maintains therapeutic range throughout the day, which we were unable to achieve with the traditional spinal cord stimulation. If you have that 24 hours a day, like if you're giving 5 times a day medication, some pain medication, those patients will have better pain relief than once a day. Same thing with electrical stimulation. We are still delivering electrical therapy to those accounts. If you maintain that closed loop and therapeutic range, then again, you will get a better result. So I think we are now getting into this funny area where we are able to decrease overall pain from other sources that include some nonceptive pains. Tim also mentioned DRG as an interesting target to affect nonceptive pain. I totally agree. I know my colleague Sapunar published the first data that they're mainly quoted in DRG clinical studies, and this is the basic science study where he clearly showed that it's not only neuropathic pain, there is also nonceptive pain that is being affected. So we are looking forward to the future.
Thank you so much, Leo. And just to emphasize and piggyback your talk, it's very important to follow this patient up and make sure you examine them every few months. Because a lot of times they say the spinal cord stimulation is not working, but then what you found is they have SI joint pain. And you just solve the issue by giving an SI joint injection and are still happy. So a lot of times the lack of follow-up sometimes makes people or patients think the therapy is not working.
Yeah, so Rita, if you remember from the Cleveland Clinic, but also my fellows here, when they come back, the patient comes back and says, I have a back pain after very successful spinal cord stimulation. The next thing what we do, we don't even look at the patient, our fellows said, okay, well, let's do the GFSS and inside and do diagnostic block right there.
Right.
90% of the problems are solved.
Right.
Leo, I just have a comment, Reda, if that's okay. I think the last point you made with regards to the cost effectiveness is, I think, something that's a very important take-home message with regards to the application of neuromodulation for back pain. I think back pain is like pandemic in chronic pain, right? So every part of the world, it's one of the most commonest problems that we encounter. And I think patients go through lots of steps. They'll go through lots of medication, opiates, gabapentinoids, physiotherapy. I know physiotherapy is important, but really a lot of health resources are going in, and eventually, now we know that if you actually put in neuromodulation in the beginning or quite early in their journey, I think you probably save a lot of money with a better outcome. So I think you made a very important point there. I think that will be a take-home message as well from your talk, that, it is very important to consider that as a part of the patient journey for long. So.
Sadiq, absolutely. There was a study published back in 2008 by Krishna Kumar. And he basically did a very detailed cost-effectiveness studies at the time with the traditional type of spinal cord stimulation. Those are difficult to conduct, but we have also lots of cost containment studies, and ongoing studies right now will also have cost containment parts. I think for payers, governments, and our patients will be enough of the evidence to say, first, as you said, we can use it early, and second, it's much more cost effective than any drugs that we use right now.
I think that's a very good point. Right. Right then, Leo, thank you so much. On behalf of me, Amar, Reda, and Gulf Pain School, I really appreciate you giving your time. Reda, do you want to add anything? You're on mute. Reda.
No, everything is good. Thank you so much, Leo, for...
Before we...
Great. Looking forward to seeing you soon, Leo, here in our region.
Yeah, thank you so much, Leo. Really appreciate it. Thanks a lot. Right, guys, we're going to take 5 minutes break, okay? We're going to cut down the break times. We're going to take 5 minutes break, and then we'll resume with Prof. Faraci and Professor Ekman. So, we have got fantastic talks lined up, so stay tuned. We're just going to play a video, some good music in the background, and you can coffee or tea or something and take a break, okay? Right, Amar, I'm just going to ask you, can you see my slides?
Yes.
Right, brilliant.
Yes.
Fantastic. Right. So I'm just gonna quickly play this, and we will be right back in 5 minutes. Okay. So Amar, are you there?
Yes, I'm here.
Brilliant, fantastic. Right, so we are good to go. I think I've already given co-hosting to Prof. Arachi, so he's there. He's already up and ready to go. Do you want to do the introduction, Amar?
Yes. Good evening, everyone. I think there's a problem with the audio. We're hearing double voice. Can you hear me?
Yes, I can hear you.
Do you hear me, guys?
You're good.
Perfect.
Good.
Okay. So it's a great pleasure to host this amazing program with amazing panel. And I have the pleasure to introduce my good friend, Agostino Verrazzi, who is a very good friend. He's talking to us all the way from Italy. He was the president of the World Institute of Pain. He ran a very interesting, great congress in Rome last May, very innovative program with hybrid program, live and virtual. We learned a lot from him, a part of having and writing hundreds of articles and book chapters. Professor Verrazzi is a great educator. He's a great researcher. And I have the pleasure to listen to him and to meet him in many occasions. Amazing charisma and amazing educator and teacher. Professor Verrazzi, the floor is yours.
Thank you very much, Amar, because I am really emotional for this nice, very nice presentation. I don't know if I deserve all these beautiful things you are telling about myself. May you see my screen?
Not yet, Professor.
Not yet, Agostino.
Let me just share it again. Let me make sure that you have a co-hosting. Yeah, you have a co-hosting. So just try it again and hopefully...
I don't know what to do.
So share screen.
Just share a screen, Agostino.
I am sharing the screen.
Press again, I think. Press again, I think.
There is a return of voice. I don't understand why. Sorry.
Yeah.
Not to worry. Yeah, we can see your screen now.
Is it okay now?
Good. Okay. Yeah, all good.
Yes,
yeah,
good.
Very
just
good.
go on the presentation.
I hear my voice 2 times. I don't know why.
Is there anything else going in the background? Because we can hear you only once. So on our side, the voice is all okay. There's no problem.
Anyway, I want to thank you again, and I also want to congratulate for excellent organization you have made, because I was very impressed with the presentation of the Gulf Pain School.
Thank you. Thanks a lot. Thank you, Agostino. Thank you. Really.
Thank you, Agostino.
You are really successful people. Amar, I want to thank also for the reminding of the Congress of last year, which was actually a big problem because of this pandemic. And we are now organizing a new Congress for this year in Rome. I hope we will be more lucky than this year instead of last year. These are my disclosures. I cannot hear very well because I don't know what is happening, but I have a return of voice.
Christina, do you want to just try one thing? I think go on the presentation mode. I can't see your whole presentation. I can only see few bits in the background. So if you want to just might sort the problem out. On the screen.
What would you suggest? I'm sorry.
So, minimize the Zoom window, I think, and, go on to, because you probably have 2 windows opened up. That might be the reason. So if you have behind your presentation, you have a Zoom window as well. So if you minimize that window, that might make things better. So, and If you want to minimize that, that might make things better.
Let me try.
Yeah, brilliant, fine. And now the presentation, yeah, in the middle, that's brilliant. Is there any way you could maximize? So if you put on the green arrow there, that might make it better. If you put on the presentation on the maximum button, on the green dot in there, yeah, green dot. You see, I've got red dot to close it, and you've got a green dot to maximize it, and that will make it bigger. Yeah, that's it.
Is it okay now?
That's it. Thank you. Fantastic.
Perfect.
All good.
Perfect.
Brilliant.
Excellent. So today I will discuss about much easier topic than the ones that have been presented by the previous speakers. I will try to make clear how acute pain may transform in chronic pain. What is the epidemiology of chronic pain? Which kind of analgesics we may use, and why there are the combination of analgesic in this so-called multimodal analgesia, and what is the current available combinations, and then I will conclude my presentation. So, at the end of the 17th century, we were taught by Mr. Descartes that pain process was a very simple process, going from periphery, as you can see here in the slide, to the center, to the brain, without any different problem. Then we have learned very well that pain is a very complex process. It's not that easy, and is a very dynamic process, actually, that is full of receptors and neurotransmitters that are changing all the time and are modulating as any other biological process. So it means, in other terms, that we cannot think that the pain transmission is a very simple process. One of the most important concepts that has been made clear in the last year is that there is a difference between acute pain and chronic pain. Acute pain is actually, as it was the first definition of pain, a process that was a defense process for our body. Chronic pain is actually recognized as a disease in its own right, and definitely is an offense for our body. But what is more clear now, if a pain symptom is not treated well, it becomes a disease, unfortunately. And it's very important that we assume we have this concept clear in our mind, because if acute pain is not satisfactorily treated, we have a sensitization of the central nervous system. And that's the reason why we must be very careful when we have a patient in acute pain, and we must treat him or her in the best possible way. So, very recently, just a few weeks ago, we have published this paper that is an epidemiological study, a very interesting epidemiological study made on primary care. On primary care, physicians are definitely the physicians that see the huge number of patients in pain. And this was very interesting because, as probably some of you know already, in Italy we have a law which is obliging doctors to report the intensity of pain in the chart of the patient. Unfortunately, with this study, we put in evidence that pain is not very often documented in the primary care setting. And the general practitioners and patients need to discuss and agree on the treatment goal before starting therapy. Chronic pain patients definitely require a personalized management based on a biopsychosocial model. It has been made clear by both Tim and Leo that this is a very important aspect. We must always keep in mind that we need to communicate with our patients, and we cannot just think that giving them a therapy, either pharmacological or multimodal, including the neuromodulation, we solve their problems. There is an interaction which is very, very important. And another topic that was very interesting is that there was a huge number of prescriptions of NSAIDs, which means, in our opinion, that pain at the first visit is mostly of low or mild intensity. Another important aspect of this study was that the pain intensity reduction was not as the exclusive outcome that the patients were waiting for, because they need absolutely to improve their quality of life. And unfortunately, the GPs alone cannot guarantee this result all the time. So we need definitely an interdisciplinary and multispecialistic approach, which is indispensable if we really want to care for our patients. One of the most amazing aspects that was put in clear, was evidenced in this study, was the high cost of the therapy for the patients. As you can see in this central bar, women therapy in between 65 years and 69 years was more than 14,000 euros a year, which means a lot of money, definitely a lot of money. It has been made clear by Leo, especially by Leo, that sometimes neuromodulation can reduce these expenses. We don't have the data about that, but definitely it is interesting to see how much it costs the therapy for people in chronic pain. Another data coming from that study was the location. The location in our body, lumbosacral location was definitely the most frequent. With 1 over 3 patients had low back pain or sacral pain. And all the rest was still in the column, upper back and neck, 15%, etc., etc. So, as I mentioned before, quality of life is very, very important. And I want to just remind a paper that we published last year on the quality of life and the disability of chronic non-cancer pain, which was very interesting because we put in evidence that moving from primary care to specialized setting, it is not so easy. As I said before, we have a law for more than 10 years now that is obliging the social security system to care for pain patients. But unfortunately, this is not completely in place at the moment. And as you can see, frequently pain clinics were not easily accessible to the patients coming from the GPs. And with the obvious consequence that there was a retard on the management by the specialist. So chronic pain is the major reason for presenteeism and absenteeism at work. And of course, this represents a big, important aspect on the socio-economic point of view, because it's affecting the population and is representing in some way one of the reasons why the chronic pain are suffering so much. Again, chronic pain negatively affects the quality of life and the general ability to work. And there is an improvement in the management and in pain intensity, but this is not always related to a better clinical setting. Another aspect that came out from this study was that women in chronic pain benefit of the treatments much more than men in a significant way. So I was talking about the problem of the quality of life, and we have shown in this other study that was published 2 years ago that unfortunately there are kind of patients, like for example the peripheral neuropathies, that are suffering for the reduction in quality of life much more than other kind of chronic pain. And I was really impressed with the presentation made by the previous colleagues and friends related to the peripheral neuropathies and the possibilities to have some influential therapy also with as a neuromodulation for those patients, because definitely it is very important, and the peripheral neuropathic pain are suffering and really have a reduction in quality of life, which is much worse than many other chronic pain patients. We also have recently published a paper on Curious on neuromodulation for pain management. This was just a couple of weeks ago in the inpatient setting, but I don't want to interfere with my previous colleagues, and I will avoid to talk about this because I don't want to step on the toes of giants of neuromodulation. Definitely neuromodulation can be of some help in treating chronic pain patients. But let's go back to the topic that I was requested to discuss, which is the pharmacological pain management and the multimodal pain management. We have a lot of analgesics. Any one of us know very well that the most diffused ones are the non-opioids with NSAIDs and paracetamol. Then we have opioids that are weak opioids or strong opioids. And then we have a series of adjuvant drugs, which are very much indeed used all around the world for many different reasons, as we will see in a few minutes. All these analgesics are acting at different level of our body, and especially of our central nervous system, starting from local anesthetics and NSAIDs that act at the peripheral level, to local anesthetic and opioids that can act on dorsal root ganglion, to opioids and NSAIDs and coxibs that can act on the central nervous system in the brain. This is a very old picture of September 1975, and there is a reason why I'm showing this picture. This person in the center with the glasses is Professor Ude. Professor Ude was moderating Professor Molina from Argentina in that Congress in Florence. This was over 40 years ago, and about 40 years ago. And Professor Ude was a very well-known pharmacologist and scientist. He was the one who, in the middle of the 60s, had shown the additive effect of aspirin and codeine, administering together these two drugs. He obtained the area under the curve that was exactly the sum of the area under the curve of aspirin alone and codeine alone, which was the first attempt of multimodal analgesia. And I'm talking about the 60s. So this concept has been taken back again from this nice group of people that was enjoying life in a way on the Lake of Como. We can recognize on the left-hand side, Professor Bonica. And then the second last one is Vittorio Ventafrida, who was the host at that time on the Lake of Como. And this was the interesting group put on by the WHO that was discussing how to treat in poor resources countries chronic cancer pain. And they were discussing about this opportunity to mix drug and to treat pain in an escalating way, depending on the intensity of pain. And this was the beginning of this very famous WHO analgesic ladder. So this is a concept of, definitely a concept of multimodal analgesia, because as much as the intensity of pain increase, you can change the kind of drug and you can mix different drugs. The concept of multimodal or balanced analgesia was diffused very much by the group of Copenhagen, directed by Kellett and al. They published in 1993 a very famous paper that was referred mainly to acute pain, postoperative acute pain, but that was presenting very clearly the concepts, the basic concepts on multimodal analgesia. Now, if you go on PubMed, you find over 3,000 papers starting from the ones that has been previously cited by me, related to the multimodal analgesia. The main concept that is clear in all these papers is the so-called opioid-sparing effects. We combine drugs, we combine analgesics in order to save the use of opioids, to reduce the use of opioids. And this is very, very important because opioids are not that simple class of drugs as it have been presented in the last 10 years, especially in the United States. But this is another very interesting study that we made a few years ago, about 10 years ago, published in 2012. This was a multi-center study made in Germany, mainly in Germany. And this was not in postoperative patients, but it was in general practitioner offices. That means the real life analgesia. And the results were really impressive because, as you can see on the right-hand side of this slide, you have the combination therapy in 93.2% of patients. And they were combining 176 different drugs together. So the monotherapy is really marginal, trivial, I would say, with less than 7% of the patients that are treated just with one drug. So this is the real life. Of course, the numbers that were in Germany 10 years ago were not the same, are not the same as today, because as you can see, there is a huge consumption of weak and strong opioids. When I talk about weak opioids in Germany, I refer mainly to tramadol, of course, and also a huge use of anticonvulsant, etc., etc. But this is very interesting study because it shows the real everyday life in our treatment. So what should be the ideal characteristic of analgesic drugs combination? Of course, an high level of efficacy, multimodal mechanisms of action, a very low risk of serious adverse effect, low incidence of burdensome side effects, very limited abuse potential, and affordability in terms of availability and costs. So, talking about the combination of drugs, you can see that in this very old systematic review published by Andy Moore, it was made clear that paracetamol alone was much less efficacious than paracetamol combined with codeine in acute pain. But when we look at the results that are obtained with codeine and paracetamol versus non-steroidal anti-inflammatory drugs alone, unfortunately, it comes out that after surgery, the efficacy of NSAIDs alone is higher, significantly higher than the efficacy of codeine and acetaminophen together. So this is interesting because it means, in other terms, that when you have an inflammatory pain, you need, absolutely you need the use of an anti-inflammatory drugs. And this is also clear by this other publication that has shown clearly how the NSAIDs may reduce the consumption of morphine. This was a very important systematic review published already 10 years ago, but the results were really impressive. So now let's go to the so-called fixed dose combination of drugs, because there are many in the market. And the one I'm presenting now is just referred to the Italian market, but you may have many of this possibility all around the world. As you can see, in general, all the drugs, all especially the opioids, are combined in general with paracetamol. In this combination that I'm presenting in this slide, there are different dosages of paracetamol, 500 milligrams till 325 milligrams, combined with oxycodone or tramadol, but mainly, as I said before, with codeine. This is a very interesting market, I would say, of analgesics, because it's what is mostly sold in the everyday practice. When we go to compare the combination with tramadol with the combination with codeine, this was another interesting study that was published many years ago. You see that there are two significant differences in the use of tramadol or codeine combined with paracetamol. The first one is somnolence, which is less with tramadol than with codeine. And the second one, which is even much more significant, is constipation. Constipation represents a problem with the use of codeine, especially with the use of codeine, which is very, very important. Why constipation is less with tramadol than with the codeine? For a very simple reason, because tramadol has a double action, and this serotonin increase in the actions of tramadol are partially relieving this, counteracting this constipating effect of the tramadol, of the opioids in general. But there is another interesting concept that came out from this study of the Margarita Puig group, which was published a few years ago. And the concept is that when you combine tramadol with NSAIDs, the constipation is even less than with the tramadol alone, which is very interesting in my opinion. And there are clinical evidences for that. Let's go now a little bit more into the details of the combination, the so-called fixed dose combination that are in the market. As I said before, there is one that is combining ibuprofen with hydrocodone, and this is clearly a very interesting drug because hydrocodone, that was developed as an antitussive agent, actually also heroin was developed in the end of the 19th century by Bayer as an antitussive drug, but this hydrocodone is 6-8 times more potent than codeine, of course, which makes a very significant differences in the analgesic efficacy. So, as you see, the combination of ibuprofen 400 milligrams with hydrocodone is definitely much more efficacious and significantly more efficacious than ibuprofen alone. The other combination is ibuprofen with oxycodone, the other fixed dose combination, which is also shown as more efficacious than the oxycodone or the ibuprofen alone, as you can see in this other slide. This has been tested in acute pain, but is exactly the same in chronic pain. When you go to see the tolerability, Tolerability is a very interesting topic because we can imagine that the tolerability is increasing if we mix two different classes of drugs. That's not the case at all. Actually, the tolerability is better combining the drugs for a very simple reason, because we reduce the dosages of each one of the drugs. So as you can see in this slide, nausea, vomiting, flatulence, somnolence are much better with the combination than with the single drug alone. Another more actual, very recent combination that has been proposed in the market is desketroprofen tramadol in a fixed dose combination. It's 25 milligrams of desketroprofen and 75 milligrams of tramadol. And there are reasons, very important reasons, why these two different drugs have been combined. As you can see in this slide, this is a very old study. Experimentally studying the efficacy of the NSAIDs, different NSAIDs, and the anti-inflammatory action, as you can see on the right-hand side with the red dot here, the most efficacious in this combination of efficacy, clinical result on pain and anti-inflammation, is definitely ketoprofen. Ketoprofen is used all around the world. So why it has been combined with tramadol? Again, tramadol is a peculiar opioid, as I said before, because it has not only the efficacy on the opioid, but also it is efficacious on the descending pathways of pain. It is increasing the analgesic efficacy of our brain. As all of you know very well, we have a descending pathway that is our defense mechanism, our natural defense mechanism, that is this descending pathway for the pain perception. Tramadol is tiredness, but the other one are really minimal, talking about 2-3% of the cases, which is more than acceptable, I think, in my opinion, also for chronic therapy. We have largely studied this combination and also published a lot on this combination, as you can see. When we concluded that a single oral dose of desketroprofen 25 milligrams plus tramadol provided good levels of pain relief with a long duration of action to more people than the same dose of the drugs alone. This was the conclusion that was made after a Cochrane review study. What it put you to sleep after lunch for many? The use of NSAIDs is frequently indispensable when we decide that our patient deserve a pharmacological management for their pain, either acute and chronic pain, because frequently, very frequently, pain. Of course, NSAIDs must be used cautiously. We don't have to forget that they have side effects, many side effects, especially in patients at risk. And of course, this is very important because it can have a negative impact on the adherence to treatment. It has been clearly shown in the literature as the adherence of patients to therapy, to prescribed NSAIDs, is significantly reduced when they have any side effects, even minimal side effects. So we know very well that, as I tried to show, but there are many data on this, that a better quality of pharmacological pain management is possible, and is, I would say, it's easy when we combine drugs in a wise way, in a professional way, in the so-called multimodal or balanced analgesia. And lastly, I would focus your attention on the fact that the fixed dose combinations may help very much the clinicians, because when we talk about the pharmacological therapy, we must keep in mind that the adherence to therapy is very, very important, as I said before, and this is exactly what we would obtain. That said, I want to invite you to join us in Rome in October this year, when we are going to organize this interesting congress. Thank you very much to the Golf Pain School for inviting me. I hope I did not borrow you too much, and I'm ready for your questions.
Thank you so much.
Always interesting, Agostino. It's always interesting to listen to you and to have your experience in teaching and in research. It's amazing that research now is the main focus for many universities and many institutions. We'd like to have your experience on that. Just a quick question that came in mind when I saw these numerous combinations. Are we doing bad in education, in teaching people about pain management?
Excuse me, Amar, I did not get the question because I was a bit confused.
Yeah. Okay,
there is a return of voice. I don't know what happened.
Can you hear me?
Yeah, I can hear you now. Yes.
Yeah, that's some delay on that. Just a quick question on when I saw this slide on numerous combinations of medications and molecules. It came on my idea that maybe you are doing very bad in educating people about medications and about multimodal. What's your thought on that?
Amar, we are very little educating pain people in general, our students on pain in general, not only on multimodal analgesia, unfortunately. Now the situation is slowly changing. And I think one of the merits of the Golf Pain School is also this, because I think these initiatives are providing definitely a good support to what the university is not doing. We need to educate people, and we need to have doctors that are educated in the right way. I am impressed with the activities of our colleagues that are very much advanced in pain management. But unfortunately, there is a huge quantity of colleagues that do not know anything about pain. And this is a topic that, in my opinion, also the Golf Pain School should keep in mind, because we need a basic education first. Because the patient cannot be treated just with neuromodulation or just with the pharmacological treatment. They need to be understood first.
Absolutely. We're having basic teaching classes about pain management on our website. Fantastic. And we're working on that to really start to surface about pain management and showing to our colleagues and our community how to build the knowledge about pain management. We're trying. We have a group, very interesting and very... Yes, Sadiq?
So, Agostino, I knew that that's going to come. So, we have actually designed a course called MAP of Pain Medicine. So, MAP stands for Management of Pain, Assessment of Pain, Anatomy, Physiology, Physiotherapy, and Psychology. So all pillars of pain management. So that's in pipeline. We'll be launching that in May. So we're going to get people from all across the world giving the lectures on basic sciences, including the psychology and physiotherapy. Because I think we want to make sure that we include all the pillars of pain management, not just interventions. We want to tell people to become a pain doctor, you need to be all-rounded. You can't just focus on interventions. You want to include psychology a bit. You want to include physiotherapy. So it's there. It's in pipeline. And thank you so much for that. I think you made a point that educating the colleagues throughout the various parts of the world is what our vision is. So we will do that. We will try our best to get there.
Thank you again, Sadiq, because I will attend this course you are mentioning with pleasure. Let me know when it will start.
It will. Great. Thank you.
We'll definitely give you the access to them, and we'll be happy to get your feedback on that and gain from your experiences.
It will be my pleasure.
Absolutely.
Great. We have a question from our friend Iyad from Syria. He's telling that and asking if NSAIDs regarding the management of spinal fusion and intestinal surgery. Maybe he's alluding to NSAIDs complications and the few in spine surgery. What's your opinion for that?
But is he asking about the topical use on spine or what? Because I don't understand.
No. It's for
systemic
use of NSAIDs. Yes, systemic.
Okay. Yes. So this is very important and extremely useful because, as I said before, when you have a lesion, a trauma, like it is in spinal surgery, you need an anti-inflammatory. So it's very important to use these drugs. We cannot forget. I have never seen, I want to be very clear, I've been doing surgery for about 40 years. I have never seen a postoperative pain patients treated without NSAIDs. Of course, we must be
maybe he was
very well documented on the side effects. What were you saying, Amar? Sorry.
I was saying that maybe he was thinking about the healing problem with the NSAIDs.
No problem. This is not a topic.
Exactly.
No, unfortunately, this is only speculation. It's not the real life.
Exactly.
It's kind of a myth around the non-steroidals, Christine. I think a lot of people think it will reduce bone healing, it will reduce wound healing.
Yeah, I know, but this is not the topic.
Fistula. Okay.
Absolutely.
Right. So it's safe to use that. That's what we wanted to tell people. It is
absolutely
safe to use that. Right. Great.
No, perfect. So thank you for the announcement for the meeting in Rome. Rome is the.
Thank you for hosting me.
Rome is my favorite place after Paris, so definitely we'll be there.
In October.
Thank you. Okay. I will see you with great pleasure, Amar, like always.
Thank you.
Thank you so much. Thank you so much, Agustino. On behalf of me, Amar, Reda, and Gulf Pain School, thank you so much for your time. Really appreciate it.
I want to congratulate again all of you for the excellent initiative.
Thank you so much. Thanks a lot.
Sadiq, I want to congratulate really deeply.
Thank you. Thank you so much, Agustino. Really appreciate it. Thanks a lot. Thank you. Right, Reda, do you want to take over?
Sure. So before I introduce my the next speaker, who is very dear to my heart and a very close friend, I would like to inform the audience that we will have our first webinar for the International Division of ASPEN, the American Society of Pain and Neuroscience, which is chaired by Dr. Dira and Dr. Dawood Said. And I'll be chairing the international division. And we're very excited to have our first webinar on May 29. So we'll have more details to follow. That would be a great opportunity for learners from all over the world. Again, sorry, there's a double echo, so I'm speaking a little bit slowly. So I have now Dr. Maxime Ekman. Dr. Ekman is a very close friend of mine. He's an educator and one of the world leaders in pain management. We serve together in multiple committees in the American Society of Anesthesiologists, as well as the ASRA. And Dr. Ekman was the chair of the ASRA meeting in 2019 and did an amazing job. So Dr. Ekman is a professor of anesthesiology at UT Health in San Antonio. He also served as the head of the pain division there, as well as a program director of the pain fellowship. And he educated multiple generations of physicians over the years. And with my great pleasure, also, Dr. Ekman has worked extensively on radio frequency, especially the shoulder, and he's one of the, actually the main driving force to get the shoulder radio frequency ablation anatomy and cadaveric dissection and make it an applicable procedure for all pain physicians to do. So without further ado, I'd like to introduce Dr. Max Ekman.
Thank you.
Please go ahead, Max.
Absolutely. Thank you, Reda. Thank you, Sadiq. Thank you, Amar, for the wonderful invitation to be here today. It's a privilege for me. I'm happy that technology is translating over into education as well. And so I think that's what we're going to need to do to accelerate the pace of learning, because medicine is so complex. But the world is becoming increasingly small, and it's so nice to be connected with you all. And Reda, it's so nice to see you, and I very much look forward to when we can see each other in person. So I'm going to go ahead. Science of managing joint pain with radio frequency. And please speak up if there's any problems, with my feed or any question. I'm going to go ahead and share my screen to unmute myself. As Reda mentioned, I am a professor of anesthesiology at UT San Antonio. I'm also the president of the Texas Pain Society. And give me a second, I'm going to advance my slide. Okay, here are my disclosures. I'm a consultant for a couple of industry companies, and I have some funded research, but I'm really going to focus on the neuroanatomy of the major joints. So first, I want to give you just a brief primer on radiofrequency ablation, just to reorient you to how it works, and understand that radiofrequency is an EMF energy that heats the tissue, but the tissue itself is what actually warms up. And so tissue factors are the primary determinant of the how the lesion shape and size are created. But nevertheless, there's a zone that's near the core of the probe that achieves thermocoagulation. And then as this zone gets far away from the tip, it decays into a cooler zone where there's no more coagulation. Now, we've made some technical advancements to try and improve the distance that we can project this zone away from the core of the needle. And internal cooling is one of those methods. The internal cooling affords the ability to push much more energy through the tissue without achieving a char or boiling point. So therefore, you can actually slightly cool the center, still keep it hot, but treat a much larger portion of tissue. And so volumetrically, this lesion has 3 to 4 times more coagulated tissue than a standard lesion. And so we've done some of these manipulations in science to try and improve our technical success with radiofrequency. Now, looking at the major joints, we have identified many aspects of the nervous system that can be leveraged to try and treat pain that is perceived in the joints. Now, one thing that is important to understand is that the major joints, just like the spine, are very complicated. You may have a very peripherally acting lesion, a peripheral inflammation, or you may have a neuritis or neuralgia, or you may have central pain that is primarily driven by the spinal cord and the brain. At all of these anatomic locations, from the neuraxis to the plexus level, to the peripheral nerve, to the articular level, there are opportunities to apply treatments. And more centrally, we would look towards neuromodulation. We have started to apply in the periphery more pulsed radiofrequency and peripheral nerve ablation. We have tended in normal ambulatory individuals not to ablate nerves in this region because of fear for functional issues, motor weakness, etc. And only in cancer situations, terminally ill situations, have we really looked at ablating in the neuraxis or plexus or major name nerve level. But now, with the emerging neuroanatomic understanding, we have the ability to target articular branches of joints, which therefore affords the potential to maintain motor function. And so that's where a lot of the interest has been in the knee joint, the hip joint, and now the shoulder joint. So I wanted to just walk you through a paradigm of how we have both made advancements in major joint pain treatment, but also found some limitations inherent to these issues. One of the seminal papers on genicular nerve ablation was in 2011 by Dr. Choi, and they targeted 3 spots on the knee joint based on the preceding preclinical information available at the time. Probably came from a lot of the orthopedic literature and also probably came from textbooks. There's another paper around this time as well. Both of those papers had short-term duration efficacy in a sham-controlled trial, and another paper in that year went out to 6 months, but the efficacy waned at 6 months. So it really only showed efficacy at 12 weeks as well. And that was using standard radiofrequency. Over the years, the neuroanatomic understanding was looked at again, and Dr. Tran and Peng really set up dissections and did 3-dimensional scanning and reconstruction. What they showed us was that there's a tremendously broad network of nerves surrounding the knee joint. In fact, along the condyles, which was treated initially, yes, there are a fair number of nerves, but the nerves also span anterior to posterior, and there are some very posterior nerves, and then there are some anterior nerves, and they are underneath the rectus femoris, near the vastus lateralis and vastus medialis. And so if you were to do the original treatment paradigm, you may miss some of the nerve endings of the joint and not get full analgesia or achieve the theoretical maximal technical success rate. Then in the next couple of years, we've seen lesion recommendations were, and there's been a discourse back and forth demonstrating, yes, the original lesions do not treat all the nerves. New lesion sites have been proposed, but yet those don't treat all the nerves either. So there's a discourse in the literature currently debating what is the correct way to lay behind the newer anatomic information, because it takes many, many years to do clinical trials. most of the available clinical trials, which have shown efficacy even out to 24 months, are based still on the original protocol described in 2011. So probably the way to interpret the current clinical original protocol was designed. And new information published by Dr. McCormick and others is proposing a modification yet again of ways to do this ablation technique to cover every single nerve possible that doesn't have motor function. So, you know, the question is, will that be effective? Understand, it's been proposed. But taking a closer look again, you've seen there is a broad neural network around the knee joint, and we are making compromises. We cannot necessarily ablate the entire joint, and it may not be safe to do so. There may be the potential for Charcot-arthropathy and other things. There may be complications if we're blocking the most relevant pain fibers for that patient. That is the hope. We have seen using augmented lesion techniques that there is a very much a chance for good outcomes. So this is a randomized study, crossover trial done by many well-known names in our field, to include Dr. Nato Platt, meaning patients who achieve greater than 50% relief, is much, much more robust in a chronic knee joint pain population than intra-articular steroids. And those of you who have treated patients with orthopedic problems for a long time probably are not surprised to see this. You know, intra-articular steroids at a point, intra-articular steroids can become a cytotoxic treatment with prolonged exposure. So not really a good, useful therapy for long-term management, yet to this day, the only other management we had was medication and surgery. So there may be a role, as evidenced by these outcomes to 6 and 12 months, that you can do joint ablation for some of these individuals. These procedures, what are the factors that increase success? And this is a review by Dr. Cohen and others. And one of the things is they've identified, you know, some of the nomenclature of the different nerves. Interestingly, I'd like to point out that this nerve labeled MR, medial retinacular, does not show up in that the Peng study that I showed you earlier, but it shows up in others. And the sample size of cadavers that we use on which to base these protocols is low. Many of the studies, for example, perhaps the biggest you'll ever see in a dissection study may be in the 20 or 30 samples of dissections, because it's so difficult and time intensive. So therefore, some anatomic studies disagree with other anatomic studies and where they're probably a good indication. And that's because of the predominance of nerves that we're able to treat safely. And lesion augmentation probably is what we need to do, because the knee joint is large. The nerve breadth, the geometry is large compared to the spine, which is where most of our tools originally came from. And it does recommend controlled blocks, but that's debated. Predicting disease burden, duration of pain, prior surgery, opioids, psychopathology, and diffuse pain symptomatology, i.e. fibromyalgia. What about prognostic blocks? We assume that they are useful to select patients for RFA. That has been shown in the cervical spine very clearly. It's been shown in the lumbar spine, but has it been shown that cooled RFA and I'm sorry, 25 subjects straight to cool RFA and 29 after a prognostic block. Now the block threshold was 50%, meaning you had to have 50% pain relief to be a success to go to RF. And that's another threshold that's debated. But the response was equivalent. The patients who achieved 50% relief at 6 months was. What does this mean? Well, it means we have a knowledge gap. It possibly means that the clinical condition, the diagnosis of the condition is much higher already in knee joint pain. The pre-test probability of the prognostic block for the knee is already very high because you know when the knee has disease, it has clear, generally we know why. And therefore, maybe a prognostic block doesn't add very much value, possibly. So that's possibly one thing you could conclude. There's a lot of detail on this slide, and I'll let you screenshot it and review it later, but understand that cooled RF seems to be showing some efficacy. There's about a 35% chance you can avoid surgery, like acid, at 12 months, where the responder group is much higher for a well-selected ablation population. The data for past 12 months is not very robust, meaning there's not a lot of data. And Dr. Caprell did a follow-up study of his original population, therefore there were only 33 patients included. Also, 20% of patients had already gone to another procedure at that point. So it wasn't durable at that point. So that's the knee joint currently. In summary, there's a lot more to it, but understand that of the major joints, the knee has the best quality. However, a lot more study is needed to improve on the technique. Now we're going to talk about the shoulder, which is my area of interest. About 6 or 7 years ago, we had the aha moment that we could do a similar concept that was being done in the knee for the shoulder joint. But we knew that the shoulder joint was a very delicate complexity of the joint. So we knew that we would first have to go back before starting a clinical protocol and do preclinical work. So this is some of our original dissections, and we published on this in 2017. This is demonstrated called suprascapular nerves accepted for shoulder pain, and you can see it inserts into the capsule posteriorly. But it also inserts superiorly in the fossa. But doing the treatment near the capsule here posteriorly can avoid the motor fibers in green and avoid the vessels in red. Dr. Peng and Tran also did a lot of work in this area, and they enter the medial trunk, and so that would preserve supraspinatus function. However, that would compromise infraspinatus function, and so that would be a concern. We looked at the axillary nerve as well, and the axillary nerve also is a major workhorse nerve for the shoulder joint. And one of the problems with the axillary nerve is that much of it is inaccessible structures nearby. So the inferior part of your joint capsule, while yes, it is innervated heavily by the axillary nerve, is probably not safe for ablation. It's probably okay for blocks and acute pain management, but not for ablation. So what we did is try to find what is essentially ascending humeral branches that go up the posterolateral aspect of the humeral on the chronic management. We did some follow-up study. This was published about a year or two later. And what we did is we needed to quantify with a frequency map, where could we find these branches of the axillary nerve accessible to ablation. And the reason why we had to do this was because what we realized when we did the original work was that the axillary nerve had a quite diverse pathway. Also speaks to the problem of peripheral with these nerves of articular fibers. The more diffuse, spread out, and irregular they get from cadaver to cadaver. And so we found in this frequency map with the axillary nerve, where what we did is we injected methylene blue, then dissected the capsule open and found where on the periosteum they were overlying, that it was this region down where the greater tubercles towards the diaphysis of the bone. So this kind of inferior posterior. If you did it in this location, you had a greater likelihood of success. We did a lot of work on the lateral pectoral nerve as well, and we found that the lateral pectoral nerve does innervate important structures. It innervates the corticoclavicular ligaments and the ACC joint pain, AC joint arthritis. Then that is a potential treatment. And it also innervated some of the anterior glenohumeral capsule. This also corroborated work from prior authors. This work was not universally seen, so subsequent neuroanatomic study to ours hasn't shown as much innervation of ligaments. So overlying the superficial aspect of the coracoid process near the thoracoacromial arteries, you can locate this nerve and block or ablate it. The subscapular nerve is the fourth nerve. It has had a little bit less attention so far, so our lab is working on that to try and improve that. But the subscapular muscle, is an internal rotator of the shoulder. Therefore, your muscle that will send an articular branch from its core neural innervation. This branch in purple, which has been highlighted by Dr. Peng and Tran, seems the upper portion of this nerve goes underneath the coracoid process, which has been cut away, and inserts into the upper anterior capsule, most likely. So we're doing work right now. This is unpublished still and in development, but here what we're doing is we're exposing the upper subscapular nerve and lower subscapular nerve and tracing that path underneath the coracoid process to see if there's a safe zone of ablation. Now, where you see here more proximally where the forceps is, that's not a great place to do an ablation treatment. If you can see below, there's a large vessel. This is your axillary artery and vein and your brachial plexus. So this would not be an ideal place to ablate. What may be more ideal, and what we've been doing early in clinical work, is to ablate it near the base of the superior base of the coracoid process, away from all of these problems. So that's something I'll speak to in a minute. If you look at the summary of the available information, you get a fuller picture. No single study, short of perhaps Dr. Tran and Peng's, has been the most complete. And Tran and Peng, again, have set the bar very high on quantitative three-dimensional neuroanatomy. But this neuroanatomy, again, reinforces what I've been talking about, that near the spinoglenoid notch posteriorly, you have a lot of fibers from the suprascapular nerve on the upper part of the glenoid neck. You do have inferior axillary fibers, but they're very inaccessible for reasons I mentioned. And in green, you do have these lateral pectoral nerves over the coracoid process as described. And in purple, this subscapular nerves, which may be accessible as well. So the one thing that is not seen in this paper, which has been better elucidated since then, is what exactly do those nerves innervate? So we see them going to the shoulder, but as Dr. Peng in his Bonica acceptance lecture said so eloquently, shoulder what? The shoulder is a very complex joint and has multiple potentially diseased soft tissue structures around it. So not only do you have the ball and socket of the glenohumeral joint itself, but you have glenohumeral ligaments, you have your subacromial subdeltoid bursa, which is this large red sac here in this image. You have your AC joint, and you have the ligaments, and you have your rotator cuff muscles themselves, which can be diseased and painful, which are not even shown here. And so the current work is looking at what specific structures are innervated by these nerves, and why that is important is maybe we can get a little more specific with, okay, you don't just have shoulder pain, you have pain coming from this particular peripheral disease. And then we take that and we need to study that and apply a block and a lesion to the nerve affecting that, and not just shotgun the entire joint the way we've done for the knee and the hip, if we have a hope of being a little bit more successful, hopefully. So the summary of shoulder nerve neuroanatomic understanding is that there's 4 principal nerves. There's many others. I'm not going to share those all, but 4 workhorses: suprascapular, axillary, lateral pectoral, and subscapular. And so this is where research should be focused if we want to do either ablation-related treatment of the shoulder joint, or, as I'll talk briefly on, peripheral neurostimulation, which could also be an option in the future. We don't have a lot of clinical information on ablation of the shoulder compared to the genicular ablation that I shared before. There's many studies on, I only showed you a small sample, many studies on genicular ablation outcome. Now, here's a study for shoulder. This is main suprascapular nerve ablation. This is what we don't want to do routinely, but this was in a palliative population who had advanced shoulder disease, non-functional due to stroke and other things. They showed that the movement, even though you weakened supraspinatus, was preserved, probably because of compensation. We went and analyzed our information and said, okay, if we're going to do articular innervation as the new paradigm of study, where is the safe place to do that? And that safe place we defined as zone A, 2 and 3. Zone A, 2, and 3 are near the joint line and superior on the head of the humerus above the surgical neck. And doing that keeps you away from the circumflex artery inferiorly, and doing it this lateral keeps you away from the medial trunks of the axillary and suprascapular nerves, so that you don't potentially weaken the patient. And so in an ambulatory, fully functional population, if you're looking at shoulder ablation, that's what you should do. Also, for the lateral pectoral nerve anteriorly, not going below the coracoid protects you from injuring the brachial plexus or the axillary artery. That's why the coracoid has been described in old literature as the lighthouse of the shoulder. It's a safe spot on which to land, but underneath could be some problems. So that's why the coracoid process is a major landmark. So we've published on some some early clinical results. This is a very elegant case, a gentleman who had chronic pain of the distal clavicle due to a fracture, tried all the rational medical management and other nerve blocks. We ended up doing a lateral pectoral ablation only for this, using some ultrasound and fluoroscopic guidance on the coracoid process. And the patient did very well, was effectively cured thereafter. This is just some three-dimensional anatomy to help you better understand where these ablation zones are. For the suprascapular articular fibers that are coming from its lateral trunk and its posterior branch, this can be accessed from the posterior shoulder, and you can ablate on the upper neck of the glenoid here, lateral to what's in this little black star, the spinoglenoid notch, which is where the spine reaches the glenoid, the scapular spine, and that's where the nerve comes out. So you can see that here in the three-dimensional image. That nerve pops out of the notch and goes towards the joint, but also sends major motor fibers and a little vessel to the infraspinatus muscle. So staying lateral to that notch is important. Also, you don't want to enter the joint cavity itself, so you have to stay in this zone. For the axillary nerve fibers, again, that we're making a compromise. We can't ablate all the fibers of the axillary nerve for safety reasons. These are some fibers that ascend the posterolateral humeral head, as you can see on both sides. This is the zone that we want to ablate, and we want to, again, stay above the surgical neck to avoid the circumflex artery. And then the lateral pectoral nerve, again, this is the zone overlying the middle aspect of the most superficial part of the coracoid. You can see it has a little bit of a complex handlebar shape because of the leverage the muscles put on it. But there's a tapering in the middle of it, and just distal to that is where the thoracoacromial arteries are. They're small. You can see them with ultrasound, or you can place a 25 gauge finder needle just in case to be safe. And that demonstrates the ablation zone there for lateral pectoral nerve. This is a summary slide, again, reinforcing the zones. Zone A, the posterior suprascapular fibers and superior ones. Zone B, axillary. Zone C, lateral pectoral. And zone D is what I'm working in development that hasn't been used so far in clinical practice that's been published, and we're doing that work. But zone D will capture two areas of nerves, we believe, which would be the upper subscapular branches, so the subscapular nerve, and fibers from an accessory pathway for the suprascapular nerve, which is the medial subacromial pathway of the suprascapular nerve that actually traverses outside of the notch. It doesn't actually go in the suprascapular notch at all. So this is kind of the summary of where I believe we should focus our clinical research for both efficacy and safety considerations and patient selection, which hopefully is increasingly disease specific as we design future trials. This was just some pilot data, retrospective, 3 lesion, not 4, meaning 3 areas. We did not do the subscapular nerve at this point in time. And in our mixed population of chronic joint pain, which had a variety of osteoarthritis, post-surgical, and rotator cuff disease, so not a very well confined population other than that they had prognostic blocks, our total response was about 50% to achieve 50% pain relief. Our cooled RFA group was a little bit better at 60% versus 33%. However, that's not statistically significant, so I can't say that that's confirmed. But we were able, in our responder group, they did average 5 to 6 months of relief in the interval of follow-up. Many of them were then lost to follow-up thereafter. So we obviously need higher quality data. This is just pilot data. Understand that we probably have a theoretical limit of the success of ablation because there is a knowledge gap in how prognostic blocks interplay with centralized joint pain, meaning you'll have a lot of patients that the block works and then the ablation completely fails 100%. And you've seen this probably in the spine once in a while. You've probably seen it if you've done a
Max, we lost you.
Things, but maybe there's something more to that. Maybe when you've got a centralized pain state and you lower the peripheral input through that pathway for a brief while, maybe that centralized pain goes down and the patient perceives that they've improved, but that's not the actual reason, the pain persists. And there's many studies that show even in healthy adults, in athletes, with acute shoulder injuries, that they have tremendous signs of pain centralization when you do even you can show that an athlete with a shoulder injury gets increased pain sensitization on their entire hemi-body on that side. So that speaks to perhaps a strong representation of the shoulder and upper extremity on the sensory map of the brain, which we know that if you look at the homunculus on the sensory motor cortex, our upper extremities occupy a tremendous amount on our cortex. So that possibly speaks to that. Just to understand that the evidence is nascent, but peripheral shoulder nerve stimulation, as in other parts of the body, could be a way to treat chronic shoulder pain. There's various techniques. And so the challenge in studying this will be to determine what's the best anatomic target, what are the best disease states. The limited amount of evidence we really have for some of these disease states. But yes, have we seen promise? Possibly. So this is just a complex summary slide. I've spoken about all of it. Basically understand that the evidence here is still nascent. We're still trying to determine what's the best clinical selection, block protocol, treatment locations, and treatment paradigm, and outcome measurement. What functional outcomes are we going to measure? There are validated orthopedic outcome measures. We know they're out there, whether it's the Oxford Shoulder Scale or what have you, pain, function, and long follow-up. We need the follow-up to a year and longer to see what we can expect and what the cost effectiveness is of these treatments. Briefly, I'm going to touch on the hip. I know time is precious, and we're doing a little bit of work here. And the hip has also enjoyed this sort of reapplication of RF from spine to major joint. And it's been identified that there are accessory branch of the femoral nerve, which innervates the joint, and these are in green, and the obturator nerve anteriorly. Thankfully, that's where most of acetabular hip pain comes from, usually in the groin and usually by these two nerves. And so we do understand, though, that there are some high value structures nearby, particularly when you're doing the obturator nerve ablation, and that includes the femoral artery. So that's something to be concerned about. And for those reasons, there have been some technical modifications and or the use of ultrasound to augment this procedure. Now, the hip joint does have posterior innervation. And so if you're ever to try, for example, to do a hip joint surgery under pure regional anesthesia, you'd be disappointed if you only did the lumbar plexus. And if you didn't do the sacral plexus, you would have incomplete. So this shows that, yes, it's undetermined whether that's needed and if it's practical. Up until now, the paradigm has used the two anterior joints, and you can see this picture down in the right on how it's accessed. And the largest, I would say the largest number of patients comes again from Leo Capral, who treated some 50 odd patients with this therapy. And this, again, retrospective. So like my pilot study, not very tightly controlled in terms of follow-up and selection, but getting a mean pain relief of significant pain relief of about 150 days, which is, again, similar to the results of the shoulder. So, showing some promise, but not strictly a highly randomized trial. Published a few months ago, and we studied the nerve to quadratus femoris posteriorly and the superior gluteal nerve. That's these two black stripes here in the X-ray image. And the answer is that it would be delicate and a little risky to ablate them. They can be done. In particular, the nerve to quadratus femoris is very close to the sciatic nerve. Actually, we had to pick away the sciatic nerve in this picture, so it's underneath. So you have to get an oblique approach to miss that. That's the sciatic nerve is in yellow. But also, the nerve to quadratus femoris innervates the muscle before it drops an articular branch. So you're committing the patient to weakness of that muscle if you ablate this nerve. So there may have to be a compromise with this joint, just as with the other two joints, that we cannot ablate every single nerve to the joint at the risk of motor injury. So the summary of the outcomes for the hip is, again, nascent in the terms of the amount of literature available, some promise, but much more study needs to be done. What I would say is the priorities for future research on using ablation and maybe stimulation for the treatment of chronic major joint pain is we have to first understand what clinical success should be, follow impact guidelines and other validated guidelines for meaningful clinical response. Is it 30% pain relief, 50% pain relief? I think you're going to see some major clinical trials published in the next few years that use different thresholds for a meaningful result. And you have to determine, is that meaningful for your patient? And you have to understand that function is a goal, and it's particularly major joints, which are used specifically for function, ADLs, walking, you name it. That's especially important for this field, even perhaps more so than for the spine, which, with the spine, pain is often functionally limiting, but mainly from a pain severity standpoint. We have to understand what the inclusion criteria should be better. We probably need to get more disease specific beyond just chronic pain. So chronic pain of a joint probably is insufficient as a selection criteria. And so we need to understand that both the knee joint, the hip, and the shoulder have soft tissue diseases that can be evaluated first, and that we should design trials that with this in mind to better target our therapy. We need to understand what a block protocol should be and study that. What are the pros and cons of using prognostic blocks, and how the spread of it, even the simple thing as the spread of anesthetic agent, is sometimes not reproducible with an RF lesion versus the block. And then we need technical improvements through better neuroanatomic understanding, which is what our lab is trying to do. We have a low sample size from which to make a lot of assumptions about how the care is driven. And if we had better imaging techniques, better ultrasound utilization, we might be able to do that in real time to find these nerves on an individual patient rather than to make a huge assumption that they're in a specific location. Also, which nerves to ablate or treat, we don't know fully. And use the best tools we have to capture the lesion safely without causing complications. And also, as in real life, we should apply co-intervention in studies because, some of the best treatments for these disorders are still very basic, like exercise, physical therapy. Especially when you're talking about major joints, there's a strong signal for the use of exercise as an intervention in and of itself. And so we should not forget that that's an important part of clinical care. So with that, I'm going to conclude my talk, and I'll take any questions.
Thank you so much, Max, for this great presentation. Amazing. And I believe that shoulder denervation is gaining a lot of traction because of your work and your group work. And I think Sadiq had an important question he'd like to ask first. So go ahead, Sadiq.
Your paper was I think I would say landmark paper, because people always did pulse radio frequency, but after the paper came out, we actually then shifted the focus from pulse to conventional RF, because nobody dared to do conventional RF unless patient had a very reduced kind of range of movements and the shoulder was basically useless kind of thing in stroke patients. But what I wanted to know is practically, how are you dealing with these patients in terms of your prognostic block? So what are you using for your prognostic block? And in terms of once you've done a prognostic block, how long you're waiting to give them RF? And I take it are you just doing cooled RF, or are you doing bipolar? So I've asked you 3 questions. So instead of asking one, so question 1 is, how do you practically deal with these patients and doctor?
Okay, yeah, absolutely.
And sorry to interrupt, but I had a fourth question.
No problem.
Sorry. The fourth question to Sadiq's question is, do you really think that prognostic block will be needed or not? Because now, even for the medial branches, the newest papers by Steve Cohen that actually questioning the value of medial branch blocks, and they actually rather even advocate to go straight to the RFA. So I was thinking the same for radio frequency of the shoulder as well, especially that we have a lot of older patients that come from very far away, and it's sometimes a nuisance to do a diagnostic block, then get them back and do an RFA. So just...
He's actually asked you 6 questions.
Yeah. That's okay, because I love talking about this part. So sorry, I'm getting that vibration if I sound like I'm having Tourette's syndrome here. So I'm turning down my volume. Okay, so just stepping back on prognostic blocks, there's a lot of both theoretical limitations and real-world problems. One, prognostic blocks have a function in that they're supposed to give you more information, diagnostic information. Now that is relevant to the spine because, as you all know, many different spinal conditions can lead to a presentation of axial pain, sometimes with tenderness as well. So you can get that with a disc herniation, you can get that with spinal stenosis, you can get that with a vertebral body fracture, or you can get it with facet disease. All will present in certain stages of the disease very similarly. And so in the spine, you're trying to select a therapy by this diagnostic block because there's a little bit of indeterminance with your clinical exam. You're not 100% certain what is the condition. Now, what Steve Cohen analyzed was that, well, it's not necessarily cost effective because not only is there a high false positive rate for blocks, there's also a high false negative rate, meaning you exclude patients that can also benefit from RF even though the block was negative. So that's a concern. And not to mention you have all these different sessions, so they're coming for 1, 2 blocks or more. Not to mention the research did a 3rd sham block in some studies. So that's not practical and it's costly. So there's an argument to be said if you have a treatment that is safe, fairly reasonably priced, and has a decent likelihood of success, maybe you should just do it, based on your clinical impression. And I think that's a good argument. And I think the current consensus guidelines for facet RF have made a little bit of a compromise between the purists who are advocating for highest technical response rate, and they would therefore use a high block threshold of 80% or more and dual blocks. And then the realists who are saying, well, it's not really cost effective and you're missing some of the population, so you might as well just RF. So the new consensus guidelines state that you do 1 block and you use a 50% threshold. That's the recommendation. So now you look at the major joints, and there was a study by McCormick there that showed that, well, they had 0 difference in the response rate based on the block. So the idea there, I believe, is multifactorial. One is that the pretest probability of pain coming from a diseased knee joint, for example, is pretty high. You have radiographic evidence of advanced cartilaginous disease. There's a scoring system. There's a validated way to evaluate that. You have MRI. And, you can examine the knee pretty easily. It's not deep inside the body like the spine. So you can actually feel on the knee joint as a clinician and you can test its stability and all these things. So when the knee is causing a problem usually. Now, 40% of the time, you still fail to treat it with the RFA. So what does that mean? Does it mean that there's more nerves involved for this pain? Is the pain more centralized, which is a high likelihood? Some of these, I always realized in my practice when osteoarthritic joint pain went from episodic and dynamic, meaning you had to load the joint to get pain in the past, but now it hurts at night, it hurts all the time, it hurts to some degree 24 hours a day. Well, maybe there's a neuropathic process now that has happened. That pain is to some degree neuropathic. And so that's why there's so much interest in DRG stimulation, like was mentioned earlier today, for joint pain, because it probably is neuropathic in some cases.
So that's probably why 40% of joint pain still fails to be responsive to RFA, no matter what the studies are showing to this day. Will expanding those locations matter? Maybe. But I still expect that the theoretical maximum will still be around 70% or something like that. Okay, so now how do I do the prognostic blocks? So the shoulder is somewhere in between, because the shoulder is a complex joint. Its mobility is extremely broad, and the number of painful, diseased soft tissue structure around the shoulder is very high. You can have subacromial bursitis. You can have AC joint arthritis. You can have ligament laxity. You can have glenohumeral joint disease, and you can have rotator cuff injury, tendinopathy, tendinitis, and tears. So that's perhaps there's a role for prognostic blocks with the shoulder. How I have approached that is the ablation zone is very broad, as you saw. Now, thankfully, the ablation zone, if you look at the linear distances in the shoulder joint, they're about 50% of the knee. The human knee joint's about twice as long, twice as deep, twice as tall. And so the nerves are spread out broader. So the shoulder has good potential. But nevertheless, that ablation zone I just put the needle tip in the center of that zone. So I actually want the block to be smaller than the zone of ablation. A 1 ml lesion volume roughly. And so I'm using a smaller block volume than the ablation volume. And so I try to cluster that block, in the center of the zone. Same concepts apply with pain diary. I'm expecting pain relief around 20 in a 24 to 40 hour period. Interestingly, there's a lot of studies on prognostic blocks that show the pharmacodynamics of relief of chronic pain after prognostic blocks is well beyond the several hours of the local anesthetic duration. So that's a whole topic for another day. The one thing you see, though, when you do prognostic blocks of major joints is that they often spread in planes that you did not expect. And that's true of the spine, but it can end up being intra-articular. Some patients have an expanded joint capsule due to acute inflammation, and so there'll actually be an infusion in the joint, and you'll see it's just in the joint. And so at that point, you have an indeterminate prognostic block. I mean, yeah, they'll get pain relief, but you haven't really proven that you need to block that spot with RFA. So that's one thing you'll see is that those blocks can actually enter the joint, and that's true for any of the major joints as well. And so I'm using bupivacaine, 0.5 ml maximal volume, a little bit of contrast, and I aim for the center of my expected ablation zone and not put it in a lot of places. And I watch for intra-articular spread, and I keep that in the back of my mind if I think that's a problem.
That answers all the questions. Thank you so much, Max. That was fantastic. I think, we threw all the questions all together, but I think you actually dissected out nicely. So, quite a lot of good take-home points there. And the use of dye is something that's quite a good point you made. Mix it with bupivacaine because then it's an intra-articular spread, so you can rule out the false positives. So that's a fantastic idea, actually. Really nice. Thank you so much. Right, Reda, off to you. I think we are pretty good. I think we covered majority of this stuff, right? So
yeah, amazing talks for amazing speakers. We're very we'd like to thank everyone for attending, all the delegates, the attendees that got 3 hours of their time, and the great faculty that came and from different parts of the world and got precious time from family to attend this. And I think this is crucial for the mission of Gulf Pain School to educate and teach a lot of delegates from all over the world, and we're very excited for future collaborations.
Thank you so much. Thank you so much.
The future is very, very soon. Next week, we're going to resume our face-to-face and live cadaveric workshop. We are restarting our activities. I think we are the first to do that with all the protections necessary for safety. So next weekend on Friday and Saturday, 26th and 27th of March, we're going to have 2 full days of cadaveric workshop for pain procedures for spine, cervical, lumbar, sacral, and we're gonna have also all the RF ablation from shoulder, hip, and knees, and we're very excited about that. It's 1 year of COVID, so starting again.
I think
that would be one of our
people who can't travel, we have
Yes.
made arrangements for them so they can actually join us on the virtual event. So we're going to do a webcasting of the cadaveric procedure, so stepwise approach. So things we're going to teach the delegates on 26th and 27th of March. We will be doing a webcasting on 28th of March and 3rd of April. And we have anatomy, sonoanatomy course lined up in April, May. So join us on social media, basically WhatsApp, Twitter, LinkedIn, and we will keep you guys updated. So thank you so much. Really appreciate everyone. Thank you, Max. Thank you, Gustino.
Thank you, Max.
Thank you.
Really appreciate
Thank
guys.
you,
Thank you
Gustino.
so much.
Thanks
and
a lot.
We will see you again in future, face to face. Okay, take care then, guys.
Take care, guys.
I'm going to close the meeting officially. Okay, take care. Bye-bye now. Bye.
Bye-bye.
Bye, everyone.
you